Continuing talking about psychopathology today. Okay, is my audio and video okay for everybody? Okay, hi Ibrahim, Ahmed, Faisal, Abrar, Khalid. Good morning, all of you. It's still morning where you are, but it's very early in the morning where I am. Yeah? Good to see you all. Good to hear you all. Okay, my friends. Yesterday, you may recall, we were talking about childhood disorders, neuropsychiatric disorders. And remember that things can be classified as psychiatric disorders, even if they are neurological disorders, if they present with abnormal behavior. So if the behavior is abnormal, they will get into the DSM-5 and be considered psychiatric or neuropsychological disorders. Okay, so yesterday, you may remember, we had finished talking about the autism spectrum, from mild to severe autism. And what makes autism especially severe in some children is they have no language at all. They do not speak, they do not communicate at all. And that would be a very severe autism. The mild form of autism, you may remember, was formerly called Asperger's disorder and is characterized by difficulty with social skills, with average verbal skills. Okay, so the person can talk, although their interaction is still abnormal in Asperger's disorder. Their verbal skills are relatively normal. Okay. Okay, now Rett syndrome is a disorder that has been taken out of the DSM-5. It is a neurological disorder. They will ask about it on USMLE. It is a disorder that is seen only in girls. It's X-linked. It very much resembles autism. It's no longer on the autism spectrum, however. It resembles autism in that there are severe social deficits. The social deficits tend to improve as the girl gets older. But there are also physical abnormalities. There are motor problems in Rett syndrome which tend to worsen as the girl gets older. Okay, so Rett syndrome is an autistic-like disorder. It has to be differentiated from the autism spectrum now. Okay, Shireen, have I answered your question? Okay, terrific. Okay. This is a disorder, by the way, autistic disorder is believed to occur in almost 1% of American children. That's a very, very high number, and it's being diagnosed more and more often. It is not known yet whether it's actually increasing in the population or just being diagnosed more because we're more aware of the symptoms of autism. And in the past, autism may have been put to mental retardation or to personality disorders. Now it is more recognized. So that may be one reason it is increasing. But there is the issue of whether it, in fact, it really is increasing. Okay. Okay, ADHD is fairly common disorder. My TA, can I have my pointer? I tried to get it myself, but was unsuccessful. So can you please put the pointer on the screen? Where are you, pointer? There you are. Okay, great. Okay, thank you. Okay, so ADHD is characterized primarily by problems paying attention such that they interfere with the ability to learn. That is, the individual is very distractible. Every little sound will cause them to lose their focus on whatever it is that they're trying to do. Okay. So there is the attention deficit. There is also, in many children, hyperactivity. Okay, the child seems to be kind of aimless, but getting into all kinds of trouble. They very often get injured accidentally because they do things compulsively, kind of impulsively. It is much more common in boys and very often is not identified until the beginning of school. Parents may think the child is just a very active child. But the teacher in school can tell the difference between that child and other children. Okay. So we have to differentiate the child who has ADHD from just a very active child. Easily distracted, as I said. Sometimes it's medical students who have ADHD, and we do have medical students with that condition, sometimes are allowed to take their exams alone in a room of their own, okay, so that they're not distracted by sounds that other people might be making. As I said yesterday, it's not linked to food coloring or sugar, although many parents think there is an association. It certainly is not harmful at all for the parents to restrict sugar and food colorings and additives in the diet. So we say to the parents, if you feel that that is helpful, please go ahead with that. Okay, but we don't have any scientific evidence that they are linked. Okay. Interestingly, the treatment for ADHD is a stimulant drug. Methylphenidate is an amphetamine. Dextroamphetamine obviously is an amphetamine. Both of those drugs are used. Methylphenidate is the one most commonly used. In the U.S., the trade name of this drug is Ritalin, R-I-T-A-L-I-N. Now, I mentioned yesterday that you will not need to know the trade names of drugs on the USMLE. But when patients report that they've been taking a certain drug, they're not going to be reporting the generic name. They're going to be reporting the brand name. Okay, so for practice, it's a good idea to know both. For the exam, all you need to know is these generic names. Okay. Now, atomoxetine is a drug that has also been approved for ADHD. Atomoxetine is a norepinephrine reuptake inhibitor. It has the advantage over the stimulants of not having any addiction potential, okay, because it does not work on the dopamine system as these two do. Okay, remember, the amphetamines cause the release of dopamine. Atomoxetine is also helpful for ADHD. It is approved by the FDA. It takes longer to work, though, and it is not as successful at controlling symptoms as the stimulants. So it is a second-line drug. Okay. The problem, of course, with amphetamines is not only do they tend to, they can be addictive, but also they can cause a loss of appetite, if you'll remember when we talked about that group. And a loss of appetite in children very often is not desirable because the child may show some delays in weight gain and growth. So we only give the medication on the days that the child has to concentrate, which is usually only on school days. Okay. Now, these two disorders are called behavior disruptive disorders. And they are also present as behavior problems. So ADHD, although it's a neurological disorder, presents as a behavior problem because children with ADHD can't sit still and can't learn well. These two disorders are behavioral disorders, and we don't know that they have any biological bases, except they are both comorbid with ADHD, and they are both comorbid also, and all three of them, ADHD, oppositional defiant, and conduct disorder, are all comorbid with substance abuse, both in the individual as they get older and in relatives of the individual. Let's try to start with conduct disorder. Conduct disorder is the little criminal, okay? It's the child who has no sense of right and wrong. It's the child who hurts other children, particularly younger children. It's the child who hurts animals purposely, okay? And it's the child over the age of 6, basically, who does not have a superego. Remember, the superego children get at about the age of 6, which basically gives them empathy and understanding of how others might feel. Kids with conduct disorder never get this, okay? So these children will do whatever they have to do to get what they want. And they can be very, very charming children. They can be very, very nice. And underneath all that, a little criminal, okay? Oppositional defiant disorder is not as bad as conduct disorder. Oppositional defiant disorder is a child who will not listen to authority figures, who basically tells the teacher, you can't tell me what to do, okay? He may say that to the teacher, may say, you're not my mother, you can't tell me what to do. And to his mother, he says, you're not my teacher, you can't tell me what to do. So nobody basically can tell this kid what to do. But he is not a criminal, he does not do bad things. He has a superego, but authority figures he will not listen to. So he's a school problem, and he's a problem with his behavior at home. And remember that these behavior disruptive disorders are present both at home and at school. If you see the problem only at home or only at school, then it is a problem with the environment, not with the child. Okay. Okay, let's take a look at this question. Okay, everybody, get your clickers ready to click in on the right answer. A 9-year-old boy with normal intelligence frequently gets into trouble at school because he blurts out answers, that means he shouts out answers, interrupts the teacher, disturbs the other students, and cannot seem to sit still in class. He also frequently injures himself during play and cannot sit still at the dinner table at home. However, the child works well and productively when alone with his tutor. So a tutor, as you know, is a private teacher, okay, a one-on-one kind of teacher. The best explanation for this child's behavior is normal for his age, ADHD, autistic disorder, oppositional defiant disorder, or conduct disorder, my friends. Okay, let's start the counter. And we started it already, and that's fine. Okay. And 78% of you have gotten it correct. And the answer is ADHD. That's right. This is attention deficit hyperactivity disorder, not one of the behavior disruptive disorders. Because this child cannot seem to sit still no matter what. He can't even sit still at the dinner table. At 9 years old, a child should be able to sit and eat a meal with the family. 3-year-old children cannot sit at the dinner table. 3-year-old children will be up and running around as soon as possible. But a 9-year-old child should be able to sit still. He's having trouble in school, which means that this attention deficit problem is interfering with his functioning. Okay, how are we doing, my friends? Most of you got that one right. Okay, good. How about this one? At 10 p.m. on a Tuesday evening, an 8-year-old boy is found alone in a supermarket. Various food packages are found hidden in his clothing. The first step in management of this situation is, and this is a little bit of a tougher question, okay? Okay, Shireen has asked me about the last question. He works well with the tutor, and you're right, Shireen. It's because he is alone with the tutor and there are no distractions. So he can learn when there's no distraction. Okay. Okay, so here we have this kid in the supermarket. It's 10 o'clock on a Tuesday night, and he's alone. The first step in management of this situation is contact the boy's school principal, report to the police, report to Child Protective Services. Remember that that is a state agency that we report to when children are abused or neglected. Evaluate the child for conduct disorder, or contact the child's parents. Okay, my friends, put up the counter. Good. Okay. Well, let's see. I'd like to see more of you answering the questions. Okay, try to put your answers on your clickers, okay, rather than in the chat box, my friends. That would be better. Okay. Because I'm watching the count. Okay. All right. And this question may be one that might be different by culture, okay? So try to think in terms of the American culture. This 8-year-old boy is alone in a supermarket at night. It gives you a little bit of a clue. Okay. Okay, my friends. C is the correct answer. About 40% of you picked C. Report to Child Protective Services. This child is being neglected. Okay. The child is in a supermarket at 10 o'clock at night alone. Nobody has reported him missing. Okay, parents probably don't care about where he is. Food packages are found in his clothing. He is stealing food. Children steal, but they only steal food if they're hungry or their family is hungry. So this child is being neglected, and we report this to Child Protective Services. Ibrahim is asking, why not D? Conduct disorder is a child who doesn't have to steal, but who's stealing because it's fun and he likes to break the law. This kid is obviously alone and neglected. Okay. Okay, Ibrahim, good. Okay, we okay with that, everyone? This is a repeating type of board question. They sometimes have this question as a child is living in a motel room with his mother and 5 siblings in one room, and he's taking money from the other children in school. He's taking their lunch money. Okay, and again, that's child neglect. That is, he doesn't have enough money for lunch. He's stealing because he's hungry. Okay, it's not conduct disorder. Report to the state. Okay, the next topic, now we're getting into the adult disorders, the clinical disorders, and some of you may be aware of this movie. How many people have seen A Beautiful Mind? Okay. Okay, so some of you have seen it. That's good. It's a very good movie because it depicts a person, a man, a real person with schizophrenia. Yes, John Nash, that is correct. Who won the Nobel Prize. Now, the work that he did for the Nobel Prize was done before he developed schizophrenia. Remember that schizophrenia typically develops in young adulthood. And John Nash was a brilliant mathematician, and the work that he did was done before he developed schizophrenia. You know, the Nobel Prize can be given many decades after the work is done. Okay. Now, John Nash came to speak at our medical school for graduation one year. He lives in Princeton, New Jersey. He came up to speak, and he stood up on the podium, and he said, "I will not be able to speak today," and sat down again. So his functioning is very marginal. Okay. Nevertheless, it's better than many people who have schizophrenia. Okay. So the hallmark of schizophrenia are psychotic symptoms. And remember, the 2 major psychotic symptoms are false beliefs, delusions, and hallucinations of various kinds, which are false perceptions. Okay? So every person with schizophrenia has had at least one episode of delusions or hallucinations. Okay. There are other psychotic disorders that are characterized by delusions and hallucinations that do not fulfill the criteria for schizophrenia. Because schizophrenia not only involves delusions and hallucinations, but it also at other times when the person is not psychotic, strange behaviors, particularly a lack of expression in the face. We call this a blunted affect. Okay. Associations between thoughts are very loose, and I'll describe that to you in just a minute. When they're having hallucinations and delusions, they don't know what's real from what's not real. And the language, form and content of language are also disturbed. So everything has to be present for at least 6 months. Okay. Okay, I'm just making a note. Thank you. Okay. Faisal is asking about visual hallucinations in the movie. In the movie, yes, they did use visual hallucinations. That's very rare in schizophrenia. They did it for the purposes of the video. Right, you're right. He had auditory hallucinations, okay, primarily. Okay, so if the patient has had symptoms for less than 6 months, we would say it looks like schizophrenia, but it isn't schizophrenia yet, and we call that schizophreniform disorder. And if it is less than 1 month, we call it brief psychotic disorder. Now, brief psychotic disorder can occur following a life stressor in anyone. It doesn't mean the person goes on to have schizophrenia. That is, they have a psychotic episode with a stressful life event, and then they go back to full former functioning. Okay. I told you I'd tell you what loose associations are, and in the building that I work in at the medical school, we have a daycare center for very ill psychiatric patients. With deinstitutionalization, most psychiatric patients in the U.S. now live away from where they go all day long. That is, they tend to live either with family members or in group homes. Then they come every day to our center by bus, and they spend the day having exercise class, cooking their lunches, having group therapy sessions. So that's the kind of thing they do all day. And then at 4 o'clock, the buses come back and they go back to their group homes. Okay. Anyway, I got into the elevator with one of these patients recently. And this morning, I've seen him many times. I don't know him personally, but I've seen him many times. I've taken the elevator with him before. Sometimes he says hello. Sometimes he seems involved in his own internal world. This morning he said hello. He was friendly. And as we were in the elevator, he said to me, "Yesterday my hair was very long, but my mother said it was risperidone. And my doctor, he's going to think about my mother and whether I am going to go bald." So that was what we call loose associations, my friends. That is, his thoughts did not hold together. He started talking about one thing, and then he started talking about something else. So even when he is not actively psychotic, his thought processes are disturbed. And after the first psychotic episode, people with schizophrenia will have more and more disturbances of thought processes. As people with schizophrenia tend to get older, their hallucinations and delusions tend to get less frequent. But their loss of ability to keep their thoughts together, their absence of facial expression, their lack of motivation, all of these things tend to get worse. The blunted affect, the lack of motivation, are called negative symptoms. So the negative symptoms seem to get worse. They are things that the person has lost from the way they used to be. Okay. Okay, so here we talked about the shorter versions, which may or may not end up being schizophrenia. Okay, now schizophrenia occurs all over the world to the same extent. It is 1% of the population. Anytime something occurs in all cultures to the same extent, it seems that it is more biological, okay, that it is not related to social or cultural issues. And in fact, schizophrenia is a neurological disorder. It is in fact a degenerative neurological disorder, but the degeneration is very slow. Men tend to get it at a younger age and tend to have a worse prognosis than females. Okay. Amir is asking, do people with schizophrenia ever get back to normal? And the unfortunate answer is no, they don't. Okay. Okay, so once you've had the symptoms, the thought problems, the hallucinations and delusions for at least 6 months, that means that the individual will have schizophrenia for life. Okay. So they will be on medication for life. People with schizophrenia cannot work because their thoughts are so jumbled, they cannot keep their thoughts together. They're not able to hold a regular job. If they do have a job, it will be at a much lower level than anything that their intellect would suggest they have. Okay. After they recognize that they have schizophrenia, people do become depressed about having such a terrible lifelong illness and sometimes try to commit suicide. Okay. And nowadays in the United States, about 50% live on their own or with family members, and 50% in some type of group home situation. Okay, schizophrenia is a very genetic disease. The rate for identical twins is higher than it is for non-identical twins, indicating a genetic component. The rates for monozygotic twins raised together, in fact, is 50%. So 50% of monozygotic twin pairs will both have schizophrenia. But then there are 50% or 53% that will not both have schizophrenia. So it's not completely genetic disorder. For a first-degree relative, a dizygotic twin, parent, or sibling, the concordance rate is 12%. Okay. Now, you'll remember that in the movie, those of you who saw it, the character John Nash was very suspicious of other people. He felt that the government was following him and trying to harm him. He also sometimes felt like the government had chosen him for special work because of his brilliant mathematical mind. So delusions of persecution or elevations of mood, delusions of grandeur sometimes occur. Hearing voices also is very common. Now, one thing you'll see here is there are no more subtypes of schizophrenia. Remember, you might have learned about the paranoid subtype and the disorganized subtype. No more subtypes. The DSM-5 has no subtypes. They simply rate schizophrenia as mild, moderate, or severe, very much like they're doing with many of the psychiatric illnesses. And, right, Abraham. And because it was very difficult to really separate the subtypes, that is, many subtypes crossed over each other, they got rid of them altogether. Okay. Okay, so some patients will hear voices. Many of them do hear voices. Some of them, like the man in the elevator with me, sometimes seemed almost incoherent because I couldn't understand what he's trying to say to me. Uninhibited, active, and aimless. Sometimes they very often have a disheveled personal appearance, pronounced thought disorder, and sometimes a person is laughing to themselves and grinning to themselves as they're listening to voices in their head. Lama's asking, how about schizophreniform? Can they recover? And the answer is yes. Schizophreniform does typically recover, and so does brief psychotic disorder. But once you've had the symptoms for 6 months, 6 months means basically it's chronic. Okay, and we'll see the 6-month thing with anxiety disorders, or also the generalized anxiety disorder has to last 6 months to be considered that disorder. Okay. And the implication is that it will last for life. Okay. There is still a catatonic specifier. That is, people with schizophrenia who are also mute. They do not speak. They barely move. They will put their body in these kinds of positions without moving for hours at a time. They may become violent. Remember that they are listening to voices in their heads that may tell them to become violent. They're very agitated or frozen in space. Okay, so that is a very severe form of schizophrenia. That is with catatonic features, or that is a catatonic specifier. Okay. Okay, and I mentioned this earlier, but let's go over this again. In schizophrenia, there are 2 types of symptoms. There are what we call positive symptoms, which are not good, but they are additional to what the person did not have before. Okay? So they never had hallucinations before they became ill, and now they have hallucinations and delusions, and hallucinations and delusions are positive symptoms. Negative symptoms are things the person has lost from the way they used to be. So they used to have an expressive face, and now they have a flat affect. This is a flat affect. Yes, I'm really very happy. No change in expression. A flat or blunted affect. Okay. So now they have no expression in their face. They also have very little motivation. That's another negative symptoms. The absence of socialization. They don't care to socialize with other people. They would like to talk to someone, but they are so flat and so withdrawn that they really can't communicate well. Okay, so these are the negative symptoms. They are very difficult to treat, whereas the positive symptoms respond to all antipsychotics. The negative symptoms don't respond very well to antipsychotic medication. Okay. The hypothesis, the dopamine hypothesis of schizophrenia is that too much dopamine in the mesolimbic system, basically in the limbic system, leads to hallucinations and delusions. Reduced dopamine in the mesocortical, that is in the cortex of the brain, leads to the withdrawal and the apathy, the negative symptoms. Okay? So there is a dysregulation of dopamine in schizophrenia. Too much in the limbic system, too little in the cortex, leading to the symptoms. Serotonin is also involved in schizophrenia, particularly seems to be involved in the negative symptoms. With respect to dopamine, dopamine 2 receptors are the receptors that are targeted by all antipsychotic medications. And they're the ones that are important, particularly in the hallucinations and delusions. Serotonin, the receptors are 2A receptors, serotonin 2A receptors. There may be excessive or abnormal regulation of serotonin, as well as dopamine in schizophrenia, and glutamate dysregulation as well. Okay. And I mentioned that schizophrenia is a neurodegenerative illness. Over years, the ventricles get larger as the brain shrinks. So the cortex atrophies, small and hypoactive frontal cortex. The temporal lobes also atrophy. So that's the site, of course, of the limbic system. Smaller size of structures in the limbic system, the left hippocampus, the amygdala. So limbic system and frontal cortex are sites of pathology for schizophrenia. Okay. Predictors for a good outcome, good prognosis. Patients who have a lot of paranoid symptoms seem to do better on medication and seem to be better functioning and have fewer negative symptoms. Late onset, tending to get it later, the outcome is better, and women do tend to get it later. A fast onset may be more responsive to drugs. Also, positive symptoms are more responsive to medications than the negative symptoms. Okay. So, very few people with schizophrenia lead completely normal lives. Some can function in society in a limited way. Some of them have repeated episodes of psychosis. And anytime somebody is psychotic, that is having hallucinations and delusions, they have to be hospitalized because they are not in touch with reality. And they are a danger to themselves. And sometimes, although rarely, a danger to others. Most people with schizophrenia cannot get their thoughts together with their actions very well, and so are generally not dangerous to the public, but they can be. And those cases where a person with schizophrenia, for example, pushes somebody off a subway platform into the path of a train, become very newsworthy, because they are quite uncommon, and it sort of feeds into the public's fear of people with mental illness. Okay, let's try this question, my friends. And I'm going to ask the TAs to put the counter on just when I start reading the answers. Okay, so I'll read the question, then put the counter on as I'm reading the answers. How's that, my TAs? Okay? Terrific. Okay, so 2 weeks after a breakup with her boyfriend, a woman insists that there are turtles in the milk in the supermarket. Of course, you have to be sure that that's not true, but of course, that's not true. Okay, so we diagnose her with what at this time? Schizophreniform disorder, paranoid schizophrenia, brief psychotic disorder, normal grief reaction, or disorganized schizophrenia. Now, we no longer have the subtypes, so if this question had been on the boards, they would not grade it, okay? But I'm going to ask you folks to answer it. Okay, my friends, how are we doing? Like to have some more responses? This is not a very hard question, right? I know our counter ran out. Okay, my friends. Okay, very good. Most of you got it right. 68% of you got it right. It is brief psychotic disorder. Okay, because, why is it brief psychotic disorder, my friends? Why is this brief psychotic disorder? Okay, Khalid, yes, it is one episode. That is correct. But that isn't the reason. The reason is that it is only 2 weeks, correct, side. And it also occurred as a result of a life-threatening, of a non-life-threatening, but just a life stressor. Breaking up with your boyfriend is not a life-threatening stressor. Okay. Right. And now he should come back, rather she should come back to normal. Okay. She should come back to normal after a few days, after a few weeks, but no more than 4 weeks. Okay. Good. Okay, so that was our first topic in psychiatric disorders, was the psychotic disorders, what are called the psychotic disorders, with the hallmark disorder being schizophrenia. Okay. This is the next group of disorders. They are called the mood disorders. They have been called the mood disorders in the past. Now they have been separated into depressive disorders and bipolar disorders. Essentially, they're in 2 chapters instead of 1 chapter in the DSM. Okay. Okay. Now, we're going to talk about mood states and how they are named, okay? When you feel appropriate to your current social situation, we would say that you have a euthymic mood or a normal mood. That is, you're normally... Okay, my friends, I'm going to just give you a minute to rest here, okay, because we had a freeze on the video. I'm going to correct the freeze on the video, and I'll be right back with you. Schizophrenia. Okay. Okay, my friends. Okay, so a euthymic mood is a normal mood, okay? A dysthymic mood would be a mild depression of mood. The individual does not feel very positive. They feel kind of down, not great, kind of worried about things that they really don't need to worry about. So this would be a mild depressive state, and this is a state that everybody experiences sometimes. So in order to have what we call dysthymic disorder, you have to feel mild depression, down mood, for at least 2 years. Otherwise, dysthymia can be a normal mood state. Okay? Depression is always abnormal. Depression is a swag symptom, suicidality, weight loss, anhedonia, or guilt, lasting at least 2 weeks. Okay? And one episode of depression, it's also called major depression or severe depression, indicates the person has major depressive disorder. Okay. 2 weeks is all you need for that. It's that bad. Okay. Hypomania is state of elevation of mood. You just feel really, really great. You feel really energetic. You feel like you can do anything. You can study all night and you're going to do great, and you will do very well. You will do very well in your classes. You'll do very well on the practice exams. It is a mild mood elevation with a positive or very little effect on functioning. So hypomania is actually a very pleasant state to be in. And people, when they get really good news, may feel really on top of the world for a while. And that would be appropriate to their current social situation. If you feel like this and nothing really good has happened, or you're not looking forward to something really good, that we might be concerned about you, that you might have a mood disorder. Okay. In mania, your elevation of mood is so intense that you get yourself into trouble. You think you can do things that you cannot do. Okay. You think that you can stop the Kaplan course right now and take USMLE today. I don't have to wait. I know everything in the books. Okay, and I don't have to study for this test. Okay, I can fly. Absolutely, Mohammed. I can fly. I can do things that are harmful. One of the things manic patients do is take out their credit card and buy things and run up huge credit card bills that they will not be able to pay. So they can really destroy their lives in a manic episode. And a manic episode, to be considered mania, has to last for 1 week. 1 week's time. Okay, 7 days. Okay. Okay, so combinations of these mood states make up the depressive disorders and the bipolar disorders. Okay. Now, how do you feel right now, my friends? How would you describe your mood right now? Okay, I'm going to see how your moods are. Moods? How would you describe your mood state right now using these terms? Hypomania. All right, that's pretty nice. Dysthymia, euthymic. Well, we're all over the place here. Okay. Do you feel appropriate to your current social situation, which is sitting in class pretty much all day today? Okay. Okay, euthymic, that's what we hope for. If you feel a little hypomanic, you may have a mood disorder, or it may be normal. Okay. It depends how long it lasts. Hypomania has to last for 4 days to be considered an abnormal mood state. Okay. But most of you, yes, are euthymic. That is, you feel appropriate to your current social situation. Okay. You only have to sit in class 6 hours today. Okay. Well, I'm glad you don't think that's all day. Okay. Okay, dysthymic disorder, we're just reviewing now. Patient is never suicidal or psychotic. They have a low mood for at least 2 years, problems with appetite, problems with sleep, but no frank weight loss, no severe weight loss. They're tired all the time. They don't think really very well about themselves, decreased self-esteem, poor concentration. So the patient is functional at a suboptimal level, and that is dysthymic disorder. Cyclothymic disorder are alternating states of hypomania, slight elevation of mood, and dysthymia chronically. So the patient is either a little up or a little down for at least 2 years. The lifetime prevalence is very similar to that of bipolar disorder, and we'll get to that in a little while. We'll get to the prevalence. Major depressive disorder is very common. It occurs in 10 to 20% of the population at some time in their lives. Bipolar disorder is, like schizophrenia, 1% of the population, and cyclothymic disorder, the same. Okay. Okay. Okay, major depressive disorder, which we have talked about before. The symptoms have to be present for 2 weeks. People tend to feel better as the day progresses. We call that diurnal improvement. We talked about that. Here are our 4 SWAG symptoms. Any one of them indicates major depression. Let's look at some of the other symptoms of major depression. Absence of pleasure, we've talked about. The anxiety. When persons feel depressed, they become very anxious. It's a very frightening feeling. Lack of motivation, they feel like they are really useless to anyone. Even somebody who's very successful will feel this way. Problems concentrating, problems with appetite. Some patients gain weight, most patients lose weight. Most patients have insomnia, some patients sleep excessively. By the way, the patients that gain weight and sleep excessively, we say have atypical depression. Atypical meaning it is not typical, okay? Because typical would be a lack of appetite and problems with sleep. Recurrent unwanted thoughts, these are obsessions. Recurrent unwanted thoughts are obsessions. Now, I show this picture because I want to point something out, and that is that if a patient has never had depression, but shows their first depressive episode in old age, over 65, we can be almost positive that the cause of the depression is a physical disease. Okay? There are a number of physical illnesses that cause depression because they alter neurotransmitter activity. And primary among these are the GI cancers, particularly pancreatic cancer. So if a patient comes in with a first-time depression, after 65, we are almost sure that they have a serious disease. Other diseases that cause depression are diabetes and hypothyroidism. So we're going to work the patient up for these disorders. Okay. Somebody is asking, Faisal is asking, can empty nest syndrome cause depression? That is, can social factors cause depression? And they can, but you will see it at a younger age. You will not see it for the first time in an elderly person. Another thing that often starts with depression is dementia. We not uncommonly have to distinguish depression from dementia. Okay. Okay, so insomnia, typically agitation or very slowed down activity. Somatic complaints, lots of physical complaints. Okay, and sometimes some patients will be so depressed that they have delusions or hallucinations. So the mood disorders, like the psychotic disorders, also involve psychotic symptoms sometimes. But remember that in the mood disorders, the mood always precedes the psychotic symptom. That is, the psychotic symptoms go along with the mood. They are mood congruent. That is, when a person is extremely depressed, at the bottom of their depression, that's when you'll see the psychotic symptoms. So what we look for when we see a patient with psychotic symptoms is, were they precipitated by a change in mood? Okay. And if they were, then we're dealing with a mood disorder rather than a psychotic disorder. Okay. A loss of sex drive, loss of interest, loss of pleasure, anhedonia. Many patients make suicide attempts or think about suicidal ideation, and about 15% will kill themselves. So this is a life-threatening psychiatric disorder. Okay. And here's a pattern that we see in depression. It's very variable by person. There'll be a depressive episode. Person will come back to normal, may have another depressive episode, and then come back to normal. One thing about the mood disorders is that patients typically come back to being completely normal and can work and resume their lives when the depression is either treated or resolves on its own. Now, each episode of major depression lasts approximately 1 year without treatment. So this is depicting a patient who did not have treatment here, and the patient's episode lasted about a year. Okay. The time between episodes is extremely variable. In some patients, it will be about a year, as it is in this patient. But in others, it may be 20 or 30 years between episodes. So we don't keep patients on antidepressants chronically unless they have had at least 2 or 3 episodes of depression. Then we keep them on the medication chronically. But if they've had just 1 episode of major depression, we keep them on the medication. We gradually increase the dose in the beginning of treatment, and we gradually decrease the dose at the end of treatment so that the person is on the medication about a year. If we didn't treat them at all, depression is self-limiting. It typically will resolve in 1 year's time, and the person will come back to normal if they don't commit suicide in that time. So we don't leave people depressed. We treat them very aggressively. And we can shorten a depressive episode from 1 year to perhaps 2 months. Okay, because remember, all antidepressants take at least 3 weeks to work. Okay, so here are some of the neurochemical changes that we see in depression. Apparently, there are decreased levels of the major behavioral neurotransmitters in brain synapses. The metabolites of them also decrease. Okay. And sometimes the metabolites are what are measured in psychiatric research rather than levels of neurotransmitter in body fluids. And we'll be talking about the metabolites probably later on today or tomorrow, a little bit more when we talk about psychopharm. Okay, depression. There is no more depression that is only in the winter. Now we know that there is a subtype of depression with seasonal onset. Remember, there used to be seasonal affective disorder, SAD, gone from the DSM-5. It is depression which is influenced by the season. It can occur during short or long days. Okay. But that it is seasonal and it recurs seasonally. The symptoms are atypical and include what we call leaden paralysis, which is a feeling like your arms and legs are so heavy you can hardly lift them. Okay, so these are atypical symptoms which we often see with the seasonal variety of depression. Okay, the bipolar disorder in particular, there are 2 types of bipolar disorder, type 1 and type 2. Okay. This is a picture of an American actress. Does anybody know who this is? If you've seen the old Star Wars movies, you may recognize this actress. Carrie Fisher, very good. Yes, it is Princess Leia from Star Wars. Okay. The reason I show Carrie Fisher's picture is that she's a very successful person. She's in her 60s now. She has been an actress. She has been a writer. She's written quite a number of books. And people with bipolar disorder can have a normal life and be very successful as long as their mood states are managed. Okay. The patient may alternate between periods of depression and mania, which would be bipolar 1 disorder, and between depression and hypomania, which would be bipolar 2, okay, disorder. Okay, depression and hypomania is bipolar 2 disorder. Okay, now when a patient is manic, and it isn't very hard, let's say, to identify a manic patient because they very often come to the attention of the police because they do crazy things like walk down the street with no clothing on. Okay? Anytime an adult is naked in public, we know that they're manic. Or they're on drugs, cocaine or amphetamines, some of the drugs that cause psychotic symptoms. That behavior is out of touch with reality. Okay? People who are manic feel that they are on top of the world. They feel fantastic, terrific, like they could do anything. They are very often irritable and do not like to be stopped in whatever it is they're doing. They get very frustrated very quickly. They don't sleep much. They don't eat much. Okay. Their ideas follow each other rapidly. You know, I want to go to Belgium. Belgium has great chocolate. I love chocolate in Belgium. Why don't we go to Belgium? Why should we go? Why don't we go right now? Let's get a plane. Let's get a plane trip. We'll go to Paris, and then we'll go to Belgium, and then we'll have a really great time in Belgium. It'll be terrific, and then we'll come home, and it'll be really great. If you talk to someone who makes you tired after you've talked to them, they may be manic. Okay? So the ideas make sense. They follow each other logically, but they are so fast that the individual that you can't really, you get exhausted listening to them. Okay. 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 And they also show something called pressured speech, where they seem compelled to speak. The person seems compelled to speak, and you can tell when the patient has pressured speech by the fact that you cannot interrupt them. So as this guy is talking with his flight of ideas, or he's talking very quickly and he's very excited about a job that he just got and it's really going to be fantastic and terrific, and you try to interrupt him, just a minute, I have to go go to an appointment. He doesn't stop. You cannot interrupt somebody who has pressured speech. So pressured speech means they're not interruptible. Okay. Question is, can children be bipolar? Thank you, Lama. I'm glad you asked that question, because children can have all the psychiatric disorders that adults have, with one exception. The personality disorders cannot be diagnosed in childhood. They can only be diagnosed after puberty. But all of the other psychiatric disorders, like bipolar disorder, major depression, cyclothymic disorder, can all be diagnosed in children. So children, yes, can be bipolar. Uninhibited behavior and increased libido are part of the picture in mania. So here's bipolar 1, which is depression and mania. And remember, a manic episode has to last 1 week. A depressive episode has to last 2 weeks for the diagnosis. So we have both in bipolar 1 disorder. But because mania is not seen in any other psychiatric disorder, one manic episode defines bipolar 1 disorder. You don't even have to catalog the depression. One manic episode, the patient has bipolar 1 disorder. Bipolar 2 disorder is characterized by depression at some times, that is, mood state lasting more than 2 weeks, and a hypomanic episode, that is, a slight elevation in mood, which lasts for at least 4 days. Now, the thing here, my friends, is that when you have a patient who has depression and you've identified they're suicidal, they have depression, how do you know that person does not really have bipolar disorder and you're just seeing the depression? Well, you really don't know that. So what we ask these depressed patients is, have you ever felt really great, really high for no reason, without drugs, just felt really high for a couple of days? If the patient says yes, we don't give them an antidepressant alone. We give them an antidepressant plus a mood stabilizer like lithium. Because what antidepressants can do in bipolar patients is they can push them up into a manic episode. So we want to know whether or not the patient has had manic symptoms in the past, and we give that patient an antidepressant for their depression with lithium or another anti-seizure or an anti-seizure medication. All of those are mood stabilizers. Okay. More than 4 episodes a year, and the patient has rapid cycling bipolar disorder, which is treated rather than with lithium, it's treated primarily with valproic acid. Okay. Okay, my friends, how are we doing? Okay, well, it looks like it's time for us to take a break. So I'll see all of you in 10 minutes' time. Welcome back, everyone. Okay. So we're talking about, just take a look at something here. Okay. We're talking about the bipolar disorders, bipolar 1 and bipolar 2, and what we call rapid cycling bipolar disorder, which is treated with anti-seizure medications rather than lithium. For all the other bipolar patients, we use lithium primarily. That is the primary drug. Now, lithium, and we'll be talking about that later on, takes at least a week to work, 1 week to work. So if a patient comes into the emergency room with mania and is ready to jump off the roof because they can fly, we give them an antipsychotic, and we start them at that time on lithium as well. But the antipsychotic will work within hours, and we have to get that patient out of that dangerous psychotic state. So we use an antipsychotic in the emergency room, typically for manic patients. Okay, so here's bipolar 1 disorder with episodes of mania. Person comes back to normal between episodes, and then we'll show depression of mood. May go right up into a manic episode, but typically has periods of time between episodes. And certainly, if we give the patient a mood stabilizer like lithium, we can avoid both the highs and the lows of bipolar disorder. And the patient will be kept in a euthymic state and very rarely have an abnormality of mood. So patients with bipolar disorder can maintain a completely normal life if we can get them properly medicated. And the medications, though, have a lot of side effects, as we'll see later on. So they're difficult to use. Lithium is very toxic. Valproic acid and the other anti-seizure medications have other side effects. They tend, for example, all of them to be teratogenic, and lithium is as well. Okay. But a patient can be maintained on these drugs and have a normal life. Bipolar 2 disorder, we may see an episode of depression, then a normal mood for years even, another episode of depression, and then a hypomanic episode. And hypomanic episodes are not always identified. So they may have occurred here, but we don't identify them because they have very little pathology associated with them. That is, a person is usually quite well functioning when they're in a hypomanic episode. But both of these are treated with mood stabilizers. We will use lithium for bipolar 1 and for bipolar 2 disorder. Okay. And we have a question. Ibrahim is asking, how many days for mania? 7, Ibrahim. 7 days. Okay. Okay. Neurochemical changes. It is believed that there are increases in the levels of the major behavioral neurotransmitters in brain synapses in mania. The patient barely sleeps. They seem to have a decreased need for sleep. They exhaust themselves, so they don't sleep and they don't eat, and they do become physically exhausted and can have physical problems because of not sleeping and not eating. Okay. Let's take a look at this question. A 65-year-old woman who was diagnosed with advanced lung cancer 3 months ago has lost 18 pounds, wakes frequently during the night, and has very little energy. Over the past month, she has been preoccupied with feelings of guilt about people I have hurt in my life and expresses concern that she will die alone. The sign or symptom most likely to indicate that this patient is experiencing a major depressive episode rather than a normal reaction to serious illness is, so this is one of those questions where you have to distinguish normal grief, okay, from or normal reaction to a serious illness. And grief could be a part of it because she has a terminal illness, okay. How do we know this is major depression and not normal grief? Is it the weight loss, the decreased energy? You can turn the counter on. Good, thank you. Difficulty sleeping, preoccupation with feelings of guilt, or concern about dying alone, which indicates that this woman needs to be treated with an antidepressant. Okay, and will benefit from it. Okay. Okay, my friends. Okay, let's see how you did. Okay, most of you got it right. 64% of you got it right is preoccupations with feelings of guilt. Okay, this is not normal. Okay, this indicates that this woman has depression and not just normal sadness or a reaction to her illness. Okay, weight loss you will see in cancer patients, obviously. Decreased energy and problem sleeping you'll also see in people with a physical illness. So those don't explain depression in this patient. Concern about dying alone is a normal concern. But this patient's preoccupation with her guilt indicates that this is major depression, and we're going to treat her with an antidepressant. Now, Dahlia is asking which of them has a worse prognosis. I think you mean, I'm not sure which two you mean, maybe between bipolar 1 and bipolar 2? Bipolar 1 is a much more serious disorder. Yes, okay, good. Bipolar 1 has a worse prognosis than bipolar 2. Okay, but both of them have a good prognosis. As long as the patient can be medicated effectively, they will have normal lives. Okay, so when we compare major depressive disorder with bipolar disorder is a more serious disorder. It tends to start at an earlier age. That is, the mean age of onset is about 30, where it's about 40 with major depressive disorder. Major depressive disorder is twice as common in women than in men, and the rates are equal in men and women for bipolar disorder. Many more people have major depressive disorder. Bipolar disorder occurs about 1% of the population, like schizophrenia. Okay. Bipolar disorder is the most genetic of all psychiatric disorders. That is, there is extremely high concordance rate in identical twins. It approaches 70%, 70%. Parents with bipolar disorder are also more likely to have children with bipolar disorder. There is a genetic component to major depressive disorder as well, but as we talked about earlier, major depressive disorder can also be caused by life stress, if it is severe enough. Parental loss, for example, before the age of 11 years has been associated with the development of major depression. So most people with major depressive disorder have biological propensity, that is, they have genetic propensity for it, but social factors can also cause it. Usually, though, as I was going to say, it is both social and biological factors. Okay. Okay, here are our next group of disorders. These are the eating disorders. And arguably, these are more common in the United States than anywhere else in the world. The eating disorders, of course, are more common in developed countries than in undeveloped countries. In developed countries, typically do not have starving people in them. Okay, that usually there are systems by which people will all be able to at least eat. Okay, okay. And in the United States, we have a problem primarily with obesity. Okay, because food is readily available and relatively inexpensive. Okay. So here I have obesity with a question mark. Is obesity an eating disorder, my friends? Is obesity an eating disorder? Let's see what you think. Some of you think it is. Some of you think it's not. And Haya's going to go both ways. She's going to say, well, it varies. It could be not. You're right, of course. Obesity is not specifically an eating disorder. Obesity is primarily a genetic characteristic. That is, people tend to weigh what their biological parents weighed in adulthood. Even if they're adopted, they will weigh what their biological parents weighed. So that also gives evidence for the genetic nature. Identical twins tend to weigh the same amount, even if they are raised in two different families. Okay, and there's a study that's been going on for many years called the Minnesota Twins Study. It's quite an old study of twins, of course, where twins who have been raised together are compared with twins who have been raised in different households. They've been adopted into different families, for example, and identical versus non-identical twins. Okay, and obesity is a factor that is very highly genetic. Okay, kind of like IQ. Okay, they're both very genetic. Okay, so obesity is not an eating disorder. Now, eating disorders are disorders in which an individual shows abnormal behavior associated with food. And the three eating disorders are, and there's a third one now, okay, bulimia nervosa, binge eating disorder, which is the new one in the DSM-5, and anorexia nervosa. Okay. The eating disorders are all characterized by, as I said, abnormal behavior. And one of the abnormal behaviors that we see is so-called compensatory behavior. That is getting rid of whatever you just ate. And there's a lot of compensatory behavior in patients with bulimia nervosa, which is vomiting. They force themselves to vomit. They very often have marks on the backs of their hands from their teeth, from putting their fingers down their throat. They use laxatives, diuretics, enemas to lose weight. They exercise excessively. A hallmark of eating disorders is hypergymnasia, excessive exercising. So in bulimia nervosa, there is the need to eat a lot of high-calorie food very quickly. And patients will do what we call binge eat. That means they will buy a big cake of some kind or a big sweet thing and eat the whole thing very, very quickly, often standing up, okay? They're not even sitting down for a meal. They are stuffing themselves with something. And many people with bulimia will tell you that they have a feeling of emptiness and aloneness, which they fill up with eating, excessive eating, and eating quickly. Then, in order not to gain weight, they will show purging behavior, vomiting. Also, they may exercise excessively. Okay, so the purging behavior is not only vomiting; it is any of these compensatory behaviors. In binge eating disorder, the difference between bulimia and binge eating disorder is there is no purging in binge eating disorder. The person just eats that large quantity of food and then does not show the compensatory behavior. Okay, so if there is the vomiting or the excessive exercising or the starvation after a binge, that is bulimia nervosa. Okay. So bulimia is fairly common. It occurs in many more women than men, so particularly occurring in young women. Okay. Teenagers, early 20s. This is a photo of teeth that have been eroded by gastric acid because the person is a repeat vomiter. Okay, and they are vomiting, they are throwing up, their acid is in their mouth, they are wearing down their front teeth and also developing dental caries in the back teeth. Very often it is the dentist who first identifies somebody who vomits as a compensatory behavior. So the marks on the back of the hands are from putting one's finger down the throat, esophageal tears and varices from repeated vomiting, enlarged or infected parotid glands also from the vomiting, and eroded dental enamel. If the patient is a laxative abuser, they may show this, which is called melanosis coli. This is a darkened or dyed area of the colon, which is pathognomonic for laxative abuse. Because many laxatives have plant dyes in them that dye the interior of the colon. It's not a dangerous situation, but it is an indicator of laxative abuse, that somebody is using and using and using laxatives. So the boards had a question where a woman comes to the doctor. She's very thin. She has diarrhea, chronic diarrhea. That's her complaint. The doctor does a colonoscopy and finds melanosis coli. and knows now that the patient is a laxative abuser. Okay. Okay, so in bulimia, we do see low serotonin concentrations. The individual is usually quite upset about their binging behavior. They can't seem to stop themselves, though. The primary treatment for bulimia is an SSRI. SSRIs are used to stop that feeling of emptiness and aloneness, and they do help with the binge eating, not so much with the compensatory mechanisms. And group therapy in a program with other people with eating disorders is always second with the SSRI. So these two things are done concurrently. Okay, the patient starts the SSRI and then goes into a treatment program. Okay. Okay, let's take a look at this picture. This is a model getting ready for a modeling show, getting ready to be dressed, and somebody got her picture. This is what she looks like undressed. It's a pretty scary picture. Do you agree, my friends? Okay, yes, 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 it's pretty awful. Okay, wow, yeah, this is what anorexia nervosa looks like. Sometimes when you see a patient like this, you're not sure if they have terminal cancer or anorexia nervosa. I usually look at the hair. If they have their hair, it's probably not terminal cancer, okay? So this is anorexia nervosa. Now, the big problem in this disease is that the individual's self-image is abnormal. And if she looks in the mirror, this woman or girl is looking in the mirror, this is what she sees. She feels like she always needs to lose some weight, even when she looks like a skeleton, which is what this woman looks like. Okay? She feels fat. That's the hallmark of the disease, feeling like you're overweight when you are grossly underweight, feeling like you always need to lose a few pounds. And they present these patients on the boards as being in a good mood, anxious to lose more weight. They're asking you to recommend a diet where they can lose more weight. They tell you that they eat in a very healthy way. They only eat salads with no salad dressing. Somebody like this should not be eating only salad with no salad dressing. Okay, so they watch their diet very closely. Now, they're very interested in food and cooking. This is not true of bulimia. This is true of anorexia nervosa. They like to cook for other people. They like to read magazines about recipes and cooking and restaurants. They may collect restaurant menus and read them frequently, but they themselves will not eat. When they don't eat, they have a feeling that they're in control of themselves. When they do eat, they have a feeling of loss of control. So very often these individuals had a very controlling mother who was basically telling them what to do all their lives. And as they get into the later teenage years, they may go on a diet. Typically, the eating disorders do start with a diet, okay? And then feel, when they don't eat, like they have self-control. When they eat, they feel bad, so they don't eat, okay? And they may show the compensatory things that the body does to protect itself from the lack of body fat, like grow some fine body hair. Lalugo is a sign of starvation. Again, it's adolescent females. And this is one of the very few potentially fatal psychiatric disorders with a mortality rate between 5 and 18%. Okay. The criteria of no menses for 3 months is no longer in the DSM-5 because many boys now are also developing anorexia nervosa. Okay. So possibly a controlling mother, family dynamics. The best type of psychotherapy for anorexia nervosa is family counseling. That is, the whole family comes in for counseling. Avoiding sexuality may be part of it, and about half of anorexics also binge and purge. So if the patient has anorexia nervosa, that is, they have the abnormal body image, but they binge and purge also, they have anorexia nervosa with bulimia. They don't have just bulimia. So the thing to look for is, do they have an abnormal relationship with food such that they are basically afraid to eat, although they're very interested in it, do not eat. Okay. And people with anorexia will tell you that they need to be this thin for their career in gymnastics or in the dance, ballet dancing. They deny that there's a problem. And that's a problem because they don't seek help and they are very resistant to treatment. The SSRIs and the antidepressants do not have a role in anorexia nervosa. Many large studies have shown that they don't work for this disorder. So when we have a patient with anorexia nervosa, we've identified her in our office or in the hospital emergency room, the management is to get her weight back to normal. If she is 18 plus, though, she must agree to go into an inpatient program or any program. If she's under 18, we can forcibly get her to eat. We can force feed her, but you probably only have to do that once because it's a very nasty procedure. But once someone's 18, they can refuse treatment for any reason. Okay. Okay, let's take a look at this question. While in her teens, a 22-year-old woman has had anorexia nervosa for a 5-year period. She has now recovered, but is now at highest risk for which of these disorders? Let's start the counter. Good. What is a person who starved for 5 years, which is what she did, had highest risk for? Okay, my friends. And 59% of you answered it correctly, and that is osteoporosis. Anyone who has been in a concentration camp or did not have food. Okay, my friends, I think I have catatonic schizophrenia again, so I'm going to stop the webcam and I'm going to get it back again, so just please bear with us. We'll be right back. Okay, I'm moving again. That feels good. Okay, my friends. Niacin deficiency, pellagra. Yes, many vitamin deficiencies and other problems, but here it says that she has recovered, which means that her vitamin deficiencies are now reversed. But the osteoporosis is something that she has because she did starve for 5 years. Okay. Okay, so we didn't have a choice of niacin deficiency, but she would be back on her correct diet now, so she would no longer have a vitamin deficiency. Okay, Haya, you're welcome. Okay, now here's our next group of disorders, and these are very, very, very common disorders in all populations in the world. Anxiety disorders are diagnosed when a person feels more fearful than they should, given what is going on in their life currently. And in the anxiety disorders, patients typically have insight. That is, they recognize that their symptoms of fear are not realistic, okay, but they cannot stop them anyway. So, for example, you might have somebody who has a phobia about snakes, and they are absolutely terrified of snakes. Even if a snake is in a cage, they're afraid of it. And this person is reading a book or watching a TV show, and a picture of a snake comes on the TV. They immediately turn off the television and won't turn it back on for an hour. And they say, this is ridiculous. I don't know why I turned off the TV. That wasn't a real snake. it's not around me anyway. But they understand that behavior is ridiculous, but nevertheless, they cannot keep the television on, and they'll keep it off for a while longer. Okay. So there is insight in the anxiety disorders. They can be chronic. They can occur only when the person sees a spider. That's a phobia, a specific phobia. Generalized anxiety disorder is chronic anxiety. That is anxiety symptoms that have been present for at least 6 months. A phobia is a specific fear of a specific thing like spiders or snakes. Or there's another type of phobia that is agoraphobia, which is fear of being exposed or out in the open. And then there is social phobia, which is now called social anxiety disorder, in which an individual has an intense fear of embarrassing themselves in a public situation. Okay, so those are the phobias. Specific phobia is treated with systematic desensitization, that is gradual exposure to snakes. A photograph of a little tiny baby snake, perhaps a toy snake, while the person is relaxed, and finally an actual snake. The patient will be able to be in the room with the snake. May not be able to actually touch it, but hopefully that would be the ultimate, that the patient could touch the snake. I know some of you are going, ooh. Okay. Agoraphobia and social anxiety disorder are treated with the SSRIs and other antidepressants. Generalized anxiety disorder, chronic anxiety disorder, is treated with antidepressants in the long term. SSRIs primarily. OCD, the feeling like you must engage in a certain behavior, which is useless, but if you don't do it, you become very, very anxious, is also treated with SSRIs in very high doses. Panic disorder is a sudden onset of intense fear without a precipitant. And the fear lasts for about 20 minutes to half an hour and then dissipates. That's also treated with SSRIs. And finally, post-traumatic stress disorder and acute stress disorder, which are now in their own category of the stress disorders. You don't need to know the categories. Post-traumatic stress disorder, acute stress disorder are the same thing. They're precipitated by a life-threatening stressor. PTSD cannot be diagnosed until 1 month has passed, and ASD is diagnosed in that first month. Okay, so there's only a timing difference here. The causes and the symptoms are the same. Okay. Okay, so generalized anxiety disorder is a person feels jumpy, worried. They have physiological symptoms, motor tension, autonomic hyperactivity, as well as psychological symptoms, apprehension, fear, worry, fatigue, sleep disturbances because of their anxiety. So there are physiological and psychological symptoms of anxiety. The physiological symptoms of anxiety can always be managed to some extent with a beta blocker. And that is what is used to manage the autonomic hyperactivity. The beta blockers do not affect the brain. They do not cross the blood-brain barrier. And so they don't affect the worrying part. They affect the physical part of anxiety, but not the emotional part. Okay, but drugs that do cross the blood-brain barrier, like alcohol and benzodiazepines, can be used to manage the not only to manage the psychological symptoms, the apprehension, the fear, and the worry. These are managed with benzodiazepines in the emergency room if there's an emergency situation of anxiety, but in the long run, these are managed with SSRIs. Okay, so the treatment is an SSRI or an SNRI. Both are indicated for generalized anxiety disorder. Okay, I'm just making a note. Okay, So these two drugs are SNRIs, serotonin and norepinephrine reuptake inhibitors. They have some advantages over the SSRIs. They tend to work about 1 week more quickly. So rather than 3 to 4 weeks for the SSRIs, 2 to 3 weeks for the SNRIs. They tend to cause fewer sexual side effects. So that's the advantage of the SNRIs. Buspirone is a non-benzodiazepine anti-anxiety agent which works by increasing serotonin rather than GABA and can be helpful for patients with GAD, generalized anxiety disorder. It has no abuse potential, no withdrawal symptoms, and is not additive with alcohol or other benzos. Okay. Okay, our next anxiety disorder, phobias. Phobias are irrational fears. Okay. So we just talked about this. I will review it. That is specific. There are 3 kinds of phobias: specific phobia, agoraphobia, and social anxiety disorder. So specific phobias, there's an identifiable object or situation. Closed places, we call that claustrophobia, or things like spiders and snakes. And the treatment is exposure, repeated exposure, while the patient is put in a relaxed state until they become desensitized, essentially. Okay. Agoraphobia is fear of being exposed or outside, or fear from being in a situation that you cannot escape from, feeling vulnerable and exposed, and the treatment for this is SSRIs. And agoraphobia can become so severe that people may not leave their houses for years because of agoraphobia. It's miraculous, I guess, or remarkable that when you put them on an SSRI, after 3 or 4 weeks, they will venture out of the house. Okay. Okay, so that is quite a life returner for people with this disorder. Okay, social phobia now is called in DSM-5 social anxiety disorder. Fear of embarrassing yourself in a public situation, and the most common social anxiety disorder is fear of public speaking. It can suddenly appear, this disorder. That is, this individual is a politician who has been speaking in front of groups for years. One day he gets up in front of a group to speak and he finds that he is having an overwhelming anxiety reaction to the thought of having to speak. That is, he becomes fearful that he's going to forget what he was going to say, or that he was going to say something wrong and embarrass himself in some way. And from then on, he finds he's unable to speak in public. Okay, so this is not a shy person. Remember, when we get to we haven't talked about it, the avoidant personality disorder is very afraid of criticism and rejection, and so he does not put himself forward, and he never really has. Okay, avoidant personality disorders are people who are extremely sensitive and very shy. Okay, so this is not that. Okay, that cannot be treated or helped with an SSRI. The personality disorders really have no treatment. The social anxiety disorder is effectively treated with SSRIs. It's also effectively treated with another group of antidepressants, the monoamine oxidase inhibitors. And phenelzine is one of those drugs that's most commonly used. And the monoamine oxidase inhibitors, you'll remember, block the breakdown of neurotransmitters in brain synapses. When you block the breakdown of the neurotransmitters, there is more neurotransmitter in the synapse. So rather than blocking reuptake, like the SSRIs and the SNRIs, the MAOIs block the enzyme that breaks down the neurotransmitters. Okay. But as we'll see, The MAO inhibitors block the breakdown of neurotransmitters in the gut as well as in the brain, causing problems with certain foods, which we will talk about. Okay. Now, the obsessive compulsive disorders have their own chapter now in the DSM-5, and they are characterized by thinking about things that make you feel very anxious. The things are always negative. You cannot get the thoughts out of your head, okay? You keep thinking about it and thinking about it. We call that obsessing. And you engage in some behavior that relieves the anxiety caused by the obsession, okay? So if you're obsessing about a bacteria and mold on your hands, you obsess about it, you can't stop thinking about it. We all have bacteria on our hands, mostly all the time. If you can't stop thinking about those bacteria, you have to do something about it. What do? You wash your hands thoroughly. You sit down in your seat again. You start thinking about the bacteria again. That is an obsession. And the compulsion, the hand washing, relieves the anxiety. Okay, my friends, I'm going to just take a look at your questions. I'm going to check to see if we have any questions. Okay. Okay, yes, classical conditioning, Haya. Yes, that was systematic desensitization. Yes, it was a type of classical conditioning. Excuse me. Now, like the other anxiety disorders, obsessive compulsive disorder is recognized by the patient as being ridiculous. That is, they know they should not be washing their hands so many times, but unless they do it, they can't really relax. They become very anxious. So they have insight, and they do seek help. There are two obsessive-compulsive entities in psychiatry. Okay, that just makes it confusing for students. There is obsessive-compulsive disorder and anxiety disorder, which is treated with SSRIs. And then there is a personality disorder, obsessive-compulsive personality disorder, which has some of the characteristic of obsessive-compulsive disorder, or OCD, but is different in that the individual feels compelled to do things repeatedly, but has no insight into the fact that what they're doing is really useless behavior. They believe that they should do this behavior and that everybody should do it too. Okay? So if they have a hand-washing obsession in obsessive-compulsive personality disorder, they say, my hands must be clean, and I wash them, therefore, every 30 minutes. But they will say that that is the way it should be done. Whereas the person with OCD has to wash his hands maybe every 30 minutes, maybe more frequently, but he says, I wish I didn't have to do this, and I know I don't have to do this, but if I don't do it, I can't relax. Okay? Okay, and we'll see more comparisons of these two disorders later on. Okay. Okay, so OCD, the anxiety disorder. Does OCD get worse in stress? Ibrahim is asking. Yes, and in fact, all psychiatric disorders worsen with life stress. And many physical disorders do as well, as you know. Yes, stress makes the symptoms of most of these disorders worse. Okay. This one is equal in males and females, although most of the anxiety disorders are more common in females. Okay. The brain activity has been studied, increased frontal lobe metabolism, and this one is interesting, increased activity in the caudate nucleus. Well, we'll see later on that there is another disorder which closely involves increased activity in the caudate nucleus, and that is Tourette's syndrome. Okay, Tourette's syndrome has a lot of similarities to OCD. Remember that in Tourette syndrome, patients have to do things repeatedly. If they don't do them, they feel compelled to do them. Touch people. It could be hand washing, although it not commonly isn't that in Tourette syndrome. But they have to engage in repeated useless behavior. Okay. The management of OCD is fluvoxamine or another SSRI. Okay, so fluvoxamine is an SSRI that's only indicated for OCD. Fluoxetine, of course, is indicated for OCD and depression and some of the anxiety disorders as well, and bulimia. Okay. Clomipramine is a cyclic antidepressant that is highly serotonergic, so serotonin seems to be the most important neurotransmitter involved in anxiety. Okay. Okay, so that was obsessive compulsive disorder. Another anxiety disorder is panic disorder. 3 attacks in a 3-week period, diagnosed as panic disorder. Okay. The individual has a sudden attack of intense autonomic stimulation. Their heart starts to race. They can't catch their breath. They hyperventilate. They may then begin to feel numbness around the mouth. Numbness in their fingertips because of hyperventilation. So they come to the emergency room. They're scared. They're scared they're having a heart attack. They're frightened they're having a stroke. This will happen with no particular precipitant. That is, they didn't see a spider or do anything in particular. It just happens de novo. Symptoms peak very quickly and dissipate fairly quickly as well. Okay, so the symptoms tend to go away on their own, but the person becomes very frightened that this is going to happen again. So they feel during a panic attack like they may be losing their mind or dying. Palpitations, trembling, sweating, they can't catch their breath, air hunger, a feeling of unreality from the hyperventilation. This one is more common in women. Okay. And patients who've had panic attacks when they were outside may become frightened to go outside, and they develop panic disorder with agoraphobia. Okay. They very often also begin worrying about their health because of having a panic attack and feeling so ill. The treatment, the management of a panic attack is to give the fastest acting benzodiazepine in the emergency room, and that's alprazolam. That's the fastest one. Diazepam is also a very fast one, but diazepam has a longer half-life, and we prefer to use a drug with a shorter half-life. Clonazepam is a longer acting drug, which is also a benzodiazepine, which can be used for the first few weeks of treatment until the SSRI is working, because the treatment is also an SSRI. For the immediate symptoms of hyperventilation, we can use breathing in and out of a paper bag, increasing carbon dioxide in the blood. Okay, my friends. Okay, here's our next group of disorders, and I think what we're going to do now is we're going to take a break before we start a whole new category, my friends. Okay? So let's take a break, and I'll see you all in 10 minutes. Okay, welcome back, everyone. We had just finished talking about the anxiety disorders, where people have insight into the fact that their fearfulness is really above and beyond what the situation would warrant. Okay. Hi. Hi, everybody. Thank you, William. Okay. I hope you're welcoming me back, but maybe you're saying hi to all the other students, and hi to everybody. Okay, good. Okay, now this group of disorders are an important group for medicine because these are disorders in which individuals have somatic or physical symptoms, but there is no medical cause, and the belief is that is, Freud described these symptoms. That is, there is an unconscious problem the person is not aware of, for which they are using the defense mechanism of somatization. Okay. So, somatization means turning things into physical symptoms. Okay. Okay. Somatic symptom disorder is the first one. It used to be called somatization disorder. Okay. Somatization disorder does not exist anymore in the DSM-5. Somatic symptom disorder has the same name as the total category. Okay. And it is characterized by physical symptoms repeatedly over years. That is, the individual has had many different physical symptoms which have never been explained by pathology. Okay, so we'd say that person has somatic symptom disorder. Okay. The next one is conversion disorder, which we will also talk a little bit more about, where there is a sudden onset of a neurological symptom, either motor or sensory, as a result of a life stressor. Okay. Hypochondriasis is out of the DSM-5. Okay. Hypochondriasis had some negative connotations. That is that a person who was a hypochondriac was somebody that you wouldn't really pay much attention to as a doctor. And that is out as a name. And the disorder is now called somatic anxiety disorder, which is actually more descriptive than hypochondriasis because the disorder involves fear of having a serious illness when you don't have it. The person continues to believe they have a serious illness even when they're reassured by doctors. Okay. And finally, body dysmorphic disorder, which now is in a different category, but it still has the same name, and that's all you need to know is the name, not the category, is a very odd disorder in which an individual feels like they look abnormal, although they don't. Okay. And one thing, you cannot diagnose body dysmorphic disorder in the presence of an eating disorder. Okay. Remember in anorexia nervosa, the individual thought that she was overweight when she was very thin. And that is the kind of thing we see in body dysmorphic disorder, but if there's an eating disorder, the diagnosis must be an eating disorder. Okay, my friends? Okay. Okay, so somatic symptom disorder, multiple unexplained symptoms over years, with an onset before the age of 30. Okay. So this is somebody who has had, as I said, many different problems. Now, remember that people with these disorders are experiencing all the symptoms they're reporting. They feel the headaches, they have the stomach problems, they have the urinary problems, but there's no pathology ever identified. Yet they are experiencing the symptoms. So they are people who always feel sick with something. Okay, so they have a pretty miserable time of life. Okay. In conversion disorder, an individual has a stressor, they see something frightening or they're involved in something. It can be something very serious, like watching your kid get hit by a car, or it could be something relatively minor, like reading an article that's very upsetting to you. Okay? Somebody filing a lawsuit against you. The individual's reaction is somatic. So rather than dealing with the issue on a conscious level, they repress the anxiety, fear caused by the stressor, and it comes out in a physical symptom. So the woman sees her kid run out in the street and get hit by a car, and she finds she can't see for 30 minutes after that. That is a conversion symptom. There's nothing wrong with her eyes, but we have to work her up, of course. It is the stressor that led to the blindness, okay, and it will resolve on its own. Similarly, an individual opens a letter that says he's being sued, or reads something in a newspaper that indicates he's involved in something bad, okay, and then he finds he can't see for a while, okay, and then his vision gradually comes back. Now, the vision may be completely lost, or it may only be partially lost. The neurological symptom can be total. The person finds they can't walk, which is what Freud saw back in the day in the 1890s as a result of the stressor. Or they just have odd feelings in their legs, tingling feelings or strange sensations. So it's neurological, motor, or sensory. And interestingly, the person does not show anxiety about the dramatic physical change. They report it in a very indifferent way. We call that la belle indifference. That is, the individual says, you know, doc, yesterday I couldn't move my leg for, I don't know, about an hour. I don't know what that was. Okay, so they don't seem worried. They don't seem upset. Okay. We had a case of a young man who came back from an Ivy League college, a very fine college, after his first year of college, where he did very, very well in college. And when he came back from college, he began to show seizures, okay? His father is a physician, and his father immediately had him admitted to the hospital. Of course, he consulted with a neurologist, and the neurologist had the young man admitted to the hospital. And the young man was worked up for any possible neurological disorder. And certainly in a young person, you might think in terms of a brain tumor, seizure disorder, a number of different things. And nothing was found, okay? And he was ultimately diagnosed with conversion disorder. Pseudo-seizures are one of the symptoms we see in conversion disorder. That is something that looks like seizures, but is not. Now, the way that they examined him in the hospital was they put him on an EEG 24-hour recording and also at the same time videotaped him. So that when he had these seizures, which he did have frequently, they looked at the EEG to see if there was any seizure activity, which there was not in this young man. Okay. But there was no evidence that he had had any trouble at school or that there was a precipitating factor. But of course there was a precipitating factor. And later on he revealed to his family and his father the fact that he was gay, okay, and that he had had a gay relationship prior to coming home from school, which had broken up, but which he could not admit to himself even that he was gay. Okay, and he was having so much difficulty accepting himself as he is that he developed this somatic symptom of pseudo-seizures. Okay? Okay. Now, Liam is asking me, what is the difference between somatic symptom disorder and conversion disorder? Okay, somatic symptom disorder is multiple physical symptoms of various types over many years. There is no specific precipitant. In conversion disorder, there is a stressor, either minor or major, and the individual shows a sudden neurological symptom as a result of the stressor. And conversion disorder typically resolves within days or perhaps weeks. Okay, have we got that, my friend? Okay. You're welcome. Okay, somatic anxiety disorder is the new term for hypochondriasis, right? This is an individual who thinks that every little mole on his hand, every little mark is going to be cancer, okay? He thinks that every headache is a brain tumor. That every time he has a upper respiratory infection, he's convinced that he has Ebola fever. Okay, so he keeps thinking that he's very sick when he isn't. And these people have miserable lives. He is not reassured by doctors. That is, you tell him, Mr. Smith, I'm looking at that mole, and that is not a melanoma. That is a normal lesion. It's not a melanoma. He's not reassured. He goes to another doctor. He goes doctor shopping. Okay, and that is characteristic of a somatic anxiety disorder. Now remember that people with depression also have a lot of fears about being sick. But in somatic anxiety disorder, we don't see a swag symptom. So we don't see depression at the same time. Okay? And the person must be worried about their health for at least 6 months and become preoccupied with their health. Medical students are notorious somatic anxiety disorder patients. We used to say you're notorious hypochondriacs. Because when you begin learning about some of these diseases that affect people your age, you begin checking for them. You're checking your nodes and you're checking your moles and you're getting yourself tested for various things. But it generally doesn't last for more than 6 months. Okay. So what do we do with patients with somatic anxiety disorder? Well, what we do with all patients with somatic symptom disorders is make another appointment for the patient at the appointment where you're seeing them for the first time. You always make another appointment, and we typically make monthly appointments, regular monthly visits. We tell the patient how much time we have to spend with them, because otherwise we will be spending all of our time with these patients with somatic symptom disorders. And we develop a trusting relationship with the patient. Okay, because these patients are very afraid of being thought of as being fakers, like they're making it up, and none of them are making it up. All of patients with somatic symptom disorders really come to you honestly and truthfully. Nobody is lying. Okay? Okay. Now, body dysmorphic disorder is under the obsessive compulsive disorders now, but it's still called body dysmorphic disorder, in that a normal looking person believes they have abnormal facial features typically, and they undergo extensive plastic surgery. So Michael Jackson is an obvious example. However, Michael Jackson lived in the show business world, which is different than the world that most of us live in. And in show business, there are lots of pressures to look a certain way and to be a certain weight. So the pressures are much harder. But these individuals typically seek plastic surgery, and plastic surgeons try not to operate on these individuals because they're never satisfied with whatever the plastic surgeon does. Okay, so this is someone with a normal appearance who feels that he or she is abnormal. Okay. Now, they had a question where a man is scarred over 50% of his face in a house fire. And the man refuses to leave the house because he's afraid that people will be looking at him. Is this body dysmorphic disorder, my friends? Or is that normal behavior? Okay, that is not body dysmorphic disorder. That is correct. That is, the person does have an abnormality. Okay, so that is normal fear, normal behavior. What we do with patients like that is we help them work on a statement that they can make to people who stare at them or who ask them what happened to them, like I was injured in a fire, I'm scarred, but I am not contagious, because that's what some people worry about, that whatever that person has, they don't want to get. So we develop a little dialogue for the patient to engage in when they are stared at by other people. Okay. Okay, I like this table because it differentiates the somatic symptom disorders from faking. Okay, somatic symptom disorders, remember, patient is experiencing disorders. Here we have the somatoform or somatic symptom disorders. Their symptom production is unconscious. They do not know that they are producing these seizures. The individual, the young man, did not know that his seizure production was unconscious, and he didn't know what the purpose of the seizures was. Okay? And what Freud would have said the purpose of his seizures was to keep his thoughts in his unconscious. That is, when he had the seizures, he wasn't thinking about the thing that was really bothering him, which was his sexual orientation. Okay. By the way, the management for that young man was to get him to accept himself as he is, as a gay man, and to have a good life, and as it accepted him, as he has accepted himself. Okay, that is the management. Okay, so somatoform disorders occur. They are completely unconscious. They're the ones we just talked about. Now, in contrast, we have malingering, which is not a psychiatric disorder. Malingering is something that has to be considered when you are seeing patients with either physical or emotional illnesses. Is the person intentionally saying they have symptoms, or even producing the symptoms, making themselves sick in order to get something that is fairly obvious? That is, the motivation is very easy to understand. The man makes believe he has pain in his neck after a car accident so that he can collect money from the other person's insurance company. That's intentional malingering. Sometimes it's not quite so bad. That is, a little kid who says, "Mom, I have a sore throat." He really doesn't have a sore throat. He makes believe he has a sore throat. He may cough for a while till he makes his throat a little bit red. So he's intentionally producing a symptom. Motivation: I don't want to go to school. Okay, I want to stay home and play video games tomorrow. Okay, so that is also malingering. He's faking, and he knows exactly why he's doing it. Okay. Then we have this disorder, a rare disorder called factitious disorder, which used to be called Munchausen syndrome. Some of you learned this as Munchausen syndrome. It is now factitious disorder. In this disorder, the person intentionally produces symptoms, fakes the symptoms, or actually makes themselves sick by drinking things that make them sick, by injecting themselves with insulin to cause them to pass out and have low blood sugar. They're doing it on purpose, but they don't know why they need to do this. Now, what they do know is that they want to be a sick person, but the motivation is so bizarre. Why would somebody want to be a sick person? For attention. There's a lot of better ways and easier ways of getting attention than making yourself so sick that you have to be in the hospital. So this is a disorder, and sometimes the individual fakes disorder or makes a child sick. And that's called factitious disorder by proxy. So although we may think the motivation is for attention, it is not an obvious motivation, and that's the point. Remember the kid who wanted to play video games? That was an obvious motivation. This one, a normal person cannot think of why somebody would do this. Okay? So it's a very strange disorder, factitious disorder. Okay, and we'll be looking at some questions on these disorders a little bit later on. PTSD is now under the trauma disorders. It was under the anxiety disorders. It has the same name. PTSD cannot be diagnosed until 1 month has gone by after the trauma. Okay? So Dahlia is asking, is there a treatment for factitious and malingering disorders? Remember, Dahlia, that malingering is not a disorder and there is no treatment. It's something that we have to consider. For factitious disorder, there is no specific treatment aside from talk therapies of various types, but there is no specific medical treatment. Okay. Okay, so post-traumatic stress disorder cannot be diagnosed unless the event that precipitated the symptoms is potentially life-threatening. Okay, so the event must be something like, and these are the ones that are mostly on the boards, rape, house fire, or robbery. Okay, so if somebody comes up to you in the street with a knife and says, give me your money, that's good enough to cause post-traumatic stress disorder. Now, not everybody who's robbed like that will develop this. Some people will, and others will not. Now, PTSD can have a delayed onset. You may have been robbed by someone and did not have PTSD after that event, but 5 years later, when a friend of yours is robbed at knife point, you start having the PTSD experiences. That is, you have a delayed onset, but now you feel very anxious every time you go outside. You won't go wear the clothing that you wore the day that you were accosted by this thief. Okay. So that's what we call avoidance of associated stimuli. You feel, oh, by the way, what defense mechanism is avoidance of associated stimuli? You won't wear the clothes that you wore the day that the attack happened. Okay. PTSD, yes, coming back from wars, certainly. PTSD is seen in soldiers. They were the first ones that it was identified in. But on the boards, they typically use these three rather than the soldier coming back from the war. But a soldier coming back from the war, absolutely. Okay. Okay, my friends. So, the symptoms, right, the symptoms for less than a month, it's acute stress disorder, more than a month, PTSD. Okay. Yes. Oh, well, the question was, it's not so much denial. Denial would be, I was not robbed at knife point. It's just a figment of my imagination. Okay. This is undoing. That is, if I don't wear the clothing that I wore that day, this cannot happen to me again. It's a kind of magical thinking. Okay. Ahmed is asking, is factitious disorder the same as factitious disorder is Munchausen syndrome. Factitious disorder by proxy is Munchausen syndrome by proxy. Okay, the term Munchausen's is not used anymore. It is factitious is used instead. Okay? You're welcome. Okay, so here we have PTSD. Okay. People with PTSD also behave differently. They seem different to their family members. They seem a little bit out of it. That is, they have some dissociation. They have trouble concentrating. They may be more irritable than they were before. They may lose their temper easily, have problems sleeping. They jump at every sound. We call that hypervigilance. So the symptoms are very closely related to symptoms of anxiety, which is why this was originally put among the anxiety disorders. And a hallmark of PTSD is re-experiencing the event. That is the hallmark. Re-experiencing the event, even when it's not happening anymore, feeling like it's happening again and again in dreams and in flashbacks during the daytime, thinking that it's happening again. Now, the people with PTSD know it's not happening again. They have insight, but they feel the anxiety just as if it was happening again. Okay. The prevalence is slightly higher in women. It can have a very long latency period. That's the woman that I told you about that was robbed at knife point and was okay for 5 years and then had PTSD. The management of PTSD, SSRIs are helpful. So SSRIs, along with therapy with other people, that is, groups of people who have experienced a similar stressor. So a therapy with other victims as well as SSRIs. And Ahmed is asking, why is it more common in women? Ahmed, that's a very good question. There are those that believe that the anxiety disorders are more often diagnosed in women because there is a bias in the diagnosis. That is, they're more expected in women. Okay. Another theory is that men self-medicate and women are less likely to self-medicate. They self-medicate with alcohol and other anti-anxiety agents, so that the actual likelihood of these disorders may be very close to equal in men and women. Okay. And remember, Abraham, that women are expected to show some emotion, and in most societies, men are expected to push their emotions down, and sometimes they push them down into their unconscious mind, okay? But they're not supposed to express as much emotion in most societies. Okay, good. You're welcome. Okay. This is our next disorder, and this is now among the stress disorders because it is precipitated by life stressors, and it's called adjustment disorder. This is among the most commonly diagnosed psychiatric disorders. Adjustment disorder is diagnosed when an individual has a life stressor of any level. It can be minor, it can be severe, that causes impairment in their functioning. And the impairment can be mild depression, anxiety, or changes in conduct. For example, start drinking alcohol excessively as a result of the life stressor. So there must be in the question an identifiable life stressor of any level. It can be finding your husband's shirt with lipstick on the collar. This is a common Western example of a shocking experience. Okay, basically finding out that your husband has been seeing another woman. Okay. Now, this is going to be a stressful life experience for women in any culture, or for men in any culture. However, what the person does now as a result of the stress is what will determine whether she has adjustment disorder or not. If she takes steps to talk to the husband, perhaps to see a lawyer, perhaps to make sure that her finances are in good conditions, those are all normal responses to this. But if she goes back upstairs, gets into bed, and doesn't take care of her kids or herself, then we would say she has adjustment disorder. Or if she's a working woman, she doesn't go to work and she loses her job. Okay? So that would be adjustment disorder. Now, the symptoms cannot fulfill the criteria for major depression. They cannot be a swag symptom. Okay? It also cannot be caused by the death of a loved one. This cannot be diagnosed. Adjustment cannot be diagnosed in patients who have lost a loved one. Okay? It cannot be diagnosed. So it's cannot be a grief response. Okay. Now, also importantly, the stressor, as I said, the stressor has to have occurred recently, within 3 months, and your symptoms cannot last for longer than 6 months after the stressor remits. So she finds this shirt. If 7 months later she's still not going to work or taking care of the kids, then we'd have to give her a mood disorder diagnosis. She could not have adjustment disorder anymore. It's only for 6 months. Okay. Okay, so that was adjustment disorder and it can manifest itself with a lot of different types of behavioral disturbances, which interfere with functioning. Okay, this is our next group of disorders. The dissociative disorders are very common in their mild form, but very rare in their severe form. Okay? Dissociative disorders are characterized by problems remembering things and sometimes by frank amnesia. And the psychological basis of these disorders is that an individual, rather than deal with a current stressor, feels like they're not completely awake and they're out of it. And they may actually forget things, okay, because of stress, not because they have a neurological injury. But that problem with amnesia leads us to think first, when we see a patient with a dissociative disorder, of a biological cause. And we must rule out the cognitive disorders, like delirium and dementia, before we can diagnose a psychiatric disorder, dissociative disorders. Remember, I told you that psychiatric disorders can be primary, that is, there's no medical or substance abuse explanation, and dissociative disorders, and all the ones we've talked about so far, are primary psychiatric disorders. Or you can see psychiatric symptoms secondary to medical conditions. And those would be typically the cognitive disorders like delirium and dementia, that there is a neurological problem which is causing the behavioral problem. So secondary psychiatric symptoms, for example, depression as a result of having pancreatic cancer, even if you don't know you have it. Having depression if you have hypothyroidism. Those are secondary psychiatric disorders or symptoms. Okay. Okay, now Amanji would like me to repeat adjustment disorder. Okay, I might have repeated it since you wrote your note, Amanji. Okay, it is characterized by functional problems after a life stressor of any level. That is, the person's functioning is impaired, either at school, at work, at home, with their relationships, and the impairment is manifested by lowering of mood, anxiety symptoms, or conduct symptoms. Okay? Okay, my friends. Okay. So we have to differentiate this from a man who comes into the emergency room with bruises on his head and memory loss. That man has a subdural hematoma. He does not have dissociative disorder, because dissociative disorders are primary psychiatric symptoms. Okay? Okay, so here is one dissociative disorder, and it is dissociative amnesia, which comes without or with a fugue state. Fugue state is a sudden wandering away from home, sudden unexpected travel. Frank amnesia is not specifically associated with traveling or finding oneself in a different place. Okay, so it can occur with or without fugue. But if there is fugue, there is also dissociative amnesia. So the correct diagnosis for that would be amnesia, even if they don't say amnesia with fugue. Okay, amnesia is the overall diagnosis. They used to be two separate diagnoses. Dissociative identity disorder is still in the DSM. This is, lay people will call this multiple personality disorder. Many personalities in one individual. It's believed to be related to childhood sexual abuse. Okay, so dissociative identity disorder is rare. Most psychiatrists have never seen a case of this disorder. This is a movie, but movie people like to make movies about it because it's very interesting. It's an interesting condition. And in this movie called Primal Fear, Ed Norton plays an altar boy, a boy who works in a church, and as an adult, he kills the priest that he worked for. He claims that he didn't kill the priest. His other personality killed the priest. So therefore, the jury should release him. His lawyer was Richard Gere. Okay. I'm not going to tell you more about it because I think you might like to see it. Primal Fear. Okay. You find out at the end what the story really is. Okay. Okay, in depersonalization disorder, this is a very common complaint of patients. That is, they'll tell you that every time they're under stress, they feel like they're watching themselves as though they were in a play. They don't really feel in the place. They feel separate from other people. They feel separated from their environment. They have a strange sense of not really being there. Okay. That is only a sense, and the patient knows that they are really there. There is no psychosis in the dissociative disorders. Okay. Okay. Adalia is saying, Dr. Jekyll and Mr. Hyde. Very much so, yes. They were two separate personalities, one very good, one very bad, all in one individual. At that time, I don't think they had a name for that condition. Okay. Okay. Let's take a look at some questions now, my friends. Okay, a 35-year-old man is complaining of insomnia, palpitations, anxiety, headache, and flatulence since he lost his job 1 month ago. He has no history of other psychiatric disorders. His mother has a history of bipolar disorder, father, alcoholism, younger sister was in rehab, that's rehabilitation for drug abuse for a few years. What is the most likely diagnosis for this man? And you could put the counter on. And that's adjustment disorder with, thank you, with anxiety, bipolar disorder, depression, GAD, generalized anxiety disorder, PTSD, or acute stress disorder. Like to see more of you answer. We have 45 people. Oh, we have 48 people in the class. Okay, my friends. So how about some more attempts? Because we have quite a number of questions now coming up. So I want to see you get in there and give it a try. Okay? Give it a try. What's the worst thing that can happen if you're wrong? Nothing. Nothing now. Get it wrong now, not on the boards. Okay, that would be a good thing. You always get the questions right if you've gotten them wrong once. Okay. Excuse me. Just a little more water. Okay, so the answer is A. 52% of you got it right. That is adjustment disorder with anxiety. That is, some of you chose D and E. Why can this not be post-traumatic stress disorder or acute stress disorder, my friends? Why can it and not be D or E? Perfect, perfect, great. Well, the duration could be, for acute stress disorder, could be less than a month. It is less than a month, but it can't be acute stress disorder because the event was not life-threatening. That's right. The event was not life-threatening. He lost his job. Well, that's pretty bad, but it's not life-threatening. Okay? And he has symptoms. This is adjustment disorder with symptoms of anxiety, the insomnia, the palpitations, the GI symptom. These are all related to anxiety, and so it is symptoms of anxiety following a stressor of any level. It could be in here we have adjustment disorder. It cannot be PTSD though, because that and acute stress disorder, because those must be a life-threatening stressor. Okay. Why not generalized anxiety disorder? One of the students is asking. Okay. Because he lost his job a month ago. He's only had symptoms for a month. If this continues for more than 6 months, he may be diagnosed with GAD. Okay? Okay. But right now, he has adjustment disorder with anxiety. Okay. Another question. A 23-year-old man is rescued from a burning building. After recovery, he has no memory of the fire. Medical examination is unremarkable. What is the diagnosis? And you can turn the counter on, and this is PTSD, dissociative amnesia, adjustment disorder, somatoform disorder, or subarachnoid hemorrhage. Okay. How are we doing, my friends? Oh, we got a lot more responses on this question. Good. Keep that going. Excellent. Excellent. Keep on going. Yes, my friends. And very nicely, too. Very nice. He has no memory of the fire. This is what? This is B, dissociative amnesia. That is, the life stressor has led to total amnesia. The signs of PTSD are increased anxiety, re-experiencing nightmares, right? They are not forgetting. Okay, so that is the correct answer. Now, because they say that medical examination is unremarkable, he does not have a physical problem. Okay, so E is not correct. Okay, my friends? Good. Next question. A 12-year-old boy is admitted to the hospital with a diagnosis of pain of unknown origin. Neurological and orthopedic exams do not identify any pathology. After 4 days in the hospital, the nurse reports that the child shows little evidence of pain and seems remarkably content. He's happy in the hospital, okay? She reports that she found a medical textbook in the boy's bedside table with a bookmark in the section Skeletal Pain of Unknown Origin. So which of the following best fits this clinical picture? Is it an adjustment disorder, a dissociative disorder, a somatoform disorder, malingering, or factitious disorder? Okay, my friends. What do we have here? Okay, coming to the end of our timing. See how you folks are doing. This is a harder question apparently because we have a toss-up here. We actually have, there were 3 choices that people are choosing. The answer to this question, let's look a little bit at it again, okay? I don't mean to hold you up because you want to know, did I get it right? Okay, let's see. The child is reading a medical textbook, and that may be because he's concerned about his condition, but there's really, the child is not showing any concern. He's showing real happiness in the hospital. He's very content. He's using that book to fake the symptoms realistically. And now the choice will be, is it malingering or factitious disorder? There is no evidence that he is avoiding anything in particular. That is, there's no evidence that he has an abusive parent that he's trying to avoid, or that he's trying to stay away from school. And by the way, kids who don't want to go to school don't fake illness enough to put themselves in the hospital. They want to be home with their video games, okay? He is lying, and this is E, factitious disorder. Okay, my friends? So a number of you picked malingering. Remember, the only people who are going to be malingering on the USMLE are people involved with the law. Everybody else is not malingering. Okay. So there's nothing that he has to gain, obviously, by this behavior. Good. Okay, now we're coming to a very interesting category, which I have referred to a number of times, and that is personality disorders. Now, in the old days, personality disorders used to be diagnosed in a different part of the DSM. It was called Axis 2. There are no more axes, talked about that, on the DSM. So there's no Axis 1, Axis 2, and all of that, and we talked about that yesterday. So the personality disorders are just another group of disorders. But they are distinguished by the fact that they are pervasive, that the individual has always had these characteristics, and that the personality characteristics interfere with their functioning, and they have no insight into the fact that they are the cause of their own problems. Now, your personality is a result of your inborn temperament, that is, your responsiveness to things that happen in your life. Some children, some babies are very anxious, some babies are very calm, and they'll sleep through everything. And those characteristics last throughout your life, okay? So that is your temperament, and that is very genetic. The temperament is acted on by the environment, the things that happen to you in your life, your experiences. And together, those experiences and environment, along with your basic temperament, form your personality. Okay. So many people will have the personality characteristics that we're going to talk about. You do not have the disorder unless the characteristics interfere with your functioning, either in relationships or at work or at school. Then if they do interfere with your functioning, then you have a personality disorder. Another thing about the personality disorders is they're generally not treatable. There's no medication for personality disorders. Psychotherapy is really pretty useless with patients with personality disorders because they don't think they have a problem, so they're not receptive to any kind of change. They don't want to change. They want everybody else to change, to conform with them. So there is an inability to adapt, inflexibility, lifelong, all areas of life, maladaptive responses to stress. These individuals are extremely annoying, and I usually say you'll be able to identify all your crazy relatives when you see the personality disorders. I don't say friends and relatives, because you wouldn't have a friend if they had a personality disorder. That is, you wouldn't see much of them anyway. But a relative is yours basically forever, and we deal with those. And as a physician, about 1% of your patients will have personality disorders, and they're yours forever also. Once you agree to see a patient, once you put their name in the appointment book, schedule them for a visit, that person is your patient forever. Okay. The only time you can refer patients to other doctors is when they have a medical condition that is not in your lexicon. That is not something that you do for personal reasons or because you're not trained to do it. Okay. Any behavioral problems that patients have, and no matter how annoying they are to you, they will remain your patient. Okay, you are going to deal with all the behavioral problems. So only the medical problems that you don't deal with. Okay. People with personality disorders don't think they have a problem. We say that their symptoms are egosyntonic. That is, their ego gets along fine with them. They think they're fine. They think they're great. They want everybody else to change. Here we have a 10 to 15% prevalence. I don't think we have that high a prevalence. I would say at least 1% of the population, maybe 2 or 3%. Hopefully, 10 to 15% of your patients will not have a personality disorder. Let me just make a note of that. Okay. Thank you for your patience with my notes. Okay. Okay, so let's look at the personality disorders, and they are in clusters or groups based on similar characteristics. And one thing that happened when the DSM-5 was written with respect to the personality disorders is the work group that was working on this particular topic, and they were all members of the American Psychiatric Association, could not decide on the changes that they had proposed. So they were arguing back and forth so much that they came up basically with ideas, but not enough of a consensus to change the personality disorders. So the DSM-4 and DSM-5 personality disorders are the same. So there's no changes in the personality disorders. Although their ideas about changes were all published in the document, the DSM-5. So what we have to worry about is only what are officially diagnoses in the DSM-5, and those have not changed. Okay, my friends. So before we get into, let's see how our timing is, okay, before we get into the individual personality disorders, it is time for our next regular break, okay? So let's take a break, and I'll see you folks in 10 minutes time. Disorders called the personality disorders. And the personality disorders come in 3 groups or clusters because they have, each cluster has similar characteristics. So the first group, cluster A, where there are 3 different personality disorders here, are strange people, odd, eccentric people. And the first, there are 3 different ones, as I said, the paranoid, schizoid, and schizotypal personality disorders. Okay, so first we'll talk about the paranoid personality disorder. This individual is extremely suspicious and mistrustful of other people, okay? But not to a psychotic degree. That is, he doesn't think that people are listening in on his phone conversations or trying to hurt him, but he thinks that everybody really has to watch out for themselves because people in general would like to get what they can from you. Okay, so he very often is a gun collector on the board questions. He collects guns. He would like to carry a gun. Okay, he may get a license to carry a gun. He is very suspicious of the doctor's motives. So you have a patient, for example, who has been a smoker for a long time, and you say, Mr. Smith, I think it's a good idea for you to get a chest x-ray. And the man says, you're just trying to make money, doctor. You're just going to get a kickback from the other doctor when I get an x-ray. You're going to get something for this. Otherwise, you wouldn't say that, okay? So he's very suspicious of the doctor's motives. He sues people at the drop of a hat. He will sue somebody because they stepped on his property. Okay, I'm just exaggerating a little bit there. But he's very litigious. That's called litigious. And he's very likely to sue doctors as well. Now, he has no thought disorder. His thoughts hold together well. He does not sound like the guy in the elevator with me. He's just a very suspicious person. Now, everybody should be a little bit suspicious. You cannot believe everything that people tell you, okay? Some people are trying to get things from you realistically, Okay? So to be a little paranoid is a good thing. It's when your paranoia affects your relationships so that you don't have friends because you don't trust anyone. You cannot work with people because you don't trust them. And that interferes with your functioning. Okay, so then it becomes a paranoid personality disorder. Okay, so there's suspiciousness, but not to a delusional degree. Okay, here's our next one. This is the schizoid personality disorder, and I show this man who's got an American Indian headdress on and a bow and arrow, probably because he doesn't like to have anything to do with society and wants to just live his life on the land. And he lives in this tiny little cabin in the woods all by himself with a dog. One of the things about the cluster A personality disorders is that they are more comfortable with animals than they are with people, because animals really don't require you to smile at them or do anything with them. Just as long as you feed them and you're kind of there sometimes, that's enough for them. And that's all that many of these personality disorders, particularly in this group, want. So this is a lifelong pattern of social withdrawal with no thought disorder. Remember that the personality disorders do not have frank psychotic symptoms, okay, with one possible exception, which we'll talk about in just a minute. Okay, so he wants to be alone. Now, when you see this patient in your office, first of all, he's going to be very ill by the time he comes in for anything, because he doesn't like any kind of social contact. He doesn't care if you like him or you don't like him. He really doesn't care what your opinion of him is, which is very unusual, okay? Some people can be a little bit schizoid. Some people like to be alone a lot of the time, but they can still have some satisfying relationships. This guy doesn't have any relationships, okay? He doesn't want to be around people. And when you come in and you see him for the first time and you say, "Hello, Mr. Smith, it's nice to see you. How are you today? You know, we're having some pretty hot weather," or something like that. People talk about the weather as a general way of making conversation. Mr. Smith says to you, "Let's get on with this. I do not want to have small talk." Okay. So he really doesn't want to chat with you, and he doesn't care what you think of him. This is very unusual. That's the schizoid personality disorder. Okay. Here we have the schizotypal personality disorder. Of all of the personality disorders, this one is the most strange of all. This is an individual who, by the way, this used to be called simple schizophrenia because they have so many negative symptoms. That is, they're very strange and weird. They have a very odd affect. They are very often quite isolated people, very odd, very eccentric. If you think about the crazy old lady in the neighborhood, and I don't care where your neighborhood is, whether it's in the Middle East, Europe, or the United States, you have a crazy old lady somewhere in the neighborhood. Somebody who looks different, who dresses strangely, who acts oddly. In the United States, you will find these individuals collecting cats, or, okay, so some folks are having trouble with the sound. Okay, and I'm going to ask my TAs to check out Hind. Sound problem. Okay. Okay, so I'm going to continue. Hopefully we can get that straightened out for you. Okay, and I think we're going to be logging in and logging out again, or logging out and logging in like I do when I have my camera problem. Okay. Okay, good, good. Okay, so this individual is very strange, but they do not have frank psychotic episodes. So they do have some thought problems and some negative symptoms. They are kind of strange looking, but they've never had hallucinations or delusions, not frank ones, okay? Yet they do have some negative symptoms. Odd, strange, weird, thought problems, the neighborhood, crazy lady, okay? That's a schizotypal personality disorder. Now in the DSM-5, DSM-5 has put the schizotypal personality disorder here in the personality disorders and in the psychotic disorders. So schizotypal personality disorder is now categorized in 2 places in the DSM. And you can see that the people who were making up the document could not decide where to put it. And since the arguments probably continued, they put it in both places just to calm all those psychiatrists down who are arguing, no, it should go here, or no, it should go there. Okay. So these are very strange, odd people. Okay, this group, cluster B, are all very dramatic and emotional. And I show a picture here of this gentleman. Does anybody know who this is? I think you probably do. He's pretty well known around the world. Who is this guy? Okay, some of you don't recognize him. Do you recognize him when he went to visit the president of North Korea recently? Here he is with Kim Jong-un, the president of North Korea. Anybody know who he is? Yes, in fact, he is an American basketball player. That's correct. He's about 7 feet tall. He is one very, very tall gentleman. His name is Dennis Rodman, okay? So Dennis Rodman is a histrionic type of person. How do we know that? Well, he dresses in a way that's very attention-getting, okay? He wears lipstick. He wears eye makeup like a woman, okay? He has multiple tattoos and piercings. His ears are pierced, his nose is pierced, everything is pierced. And his main ambition is to be noticed. And that is the histrionic type. Now, I don't know if he has the personality disorder, but he certainly is a histrionic type. People with this personality disorder are so interested in attention that they neglect their relationships. So if he had the personality disorder and he went to a party with this young woman, if somebody else at the party paid attention to him, he would go up with them and leave her alone. Okay, and so she says, I don't want anything to do with you. And he says, oh, women are crazy, okay? But really, he is the one who is not sticking with her, okay? So these people are very often in show business. They very often go from partner to partner, husband and husband and husband, or wife and wife and wife. They can be male or female. And the men, we call this the Don Juan type, the man who wants to attract many, many women. So they end up being quite lonely people. They're very seductive. They're particularly seductive with doctors. These are the ones that will come up and ask you out. Very flirtatious. And that is the histrionic personality disorder. Okay. That's why he goes to North Korea. Absolutely right. He goes to North Korea because he's going to be the center of attention there, and then he makes the world stage, okay? And he's in all the media. Okay. Okay. This is not a costume party, and that's what these people look like, okay? You can see everybody else is kind of dressed about the same, but he looks very different. He's 7 feet tall, and he's wearing a hat that makes him a few inches taller than that. Okay. So that's not a costume party. Okay. Okay, so that's the histrionic personality disorder. And when they come to the doctor, they describe their symptoms very dramatically. Doctor, I think I had I almost died last night. I was so sick, I almost died. My fever was off the charts. I couldn't even measure it with my thermometer. Now, they're not lying and they're not faking. They're just looking for attention. They bring gifts for people in the office. Everybody knows who this person is. Okay. And if you were in a big classroom, all of you would be turning to the person who wants the most attention right now. And we all know who the histrionic type was. Okay. Okay, here's our next personality disorder. This is the narcissistic personality disorder, the person who is extremely self-involved, who thinks that she is more beautiful and more perfect than anybody else. She thinks that she is smarter, better in every way. And she'll say things like, "Do you know who I am?" on the board questions. Okay. She has a sense of self-importance, and she also wants attention, but it comes from her sense of self-importance. The histrionic personality disorder does not have this grandiose sense. Individuals like this have very fragile self-esteem. They're very easily begin to worry about themselves. They are very angry at people who criticize them. So this is the narcissistic. Okay, and if you are their doctor, they will avoid any kind of treatment that might involve damaging their physical appearance. Okay, and they'll avoid that. And they'll say things to you like, "Do I have to wait in the office with all these other people? Like, don't you recognize how special I am?" Or they might say, "What medical school did you graduate from?" "Oh, I can only see a doctor who graduated from a top medical school." Okay, so this is the narcissistic. And like the other personality disorders, it's okay to be a little bit narcissistic. You know, when you walk by the mirror in the morning and you're checking to make sure everything is in place, you look in the mirror and you say, "Not bad, pretty good. I look pretty good." That's a good thing. It's a good thing to think that you look appropriate and good. Okay? It's when you think you look good and everybody else looks bad, that's a problem. This is the person who has already passed USMLE, and you tell them, "You passed. I just passed USMLE," and they say, "That's very nice," but they're really very, very angry that you passed. Okay? So even though they already did it, they're not happy for you. That is the narcissistic person. Okay, so we've gotten through some of our relatives so far, hopefully. Okay. Okay. This is the borderline personality disorder. This one's really bad. This is a really bad one. These individuals are extremely unstable, and we have talked about them before. They are the ones who use splitting as defense mechanisms. They love you immediately when they meet you. They think you're fantastic. And then you do one thing that they don't like, and they now think you're terrible. It is very hard for them to see people as being good people, but a little bit flawed. They have to put you into a category of good or bad. Okay. They're very impulsive. They do things on the spur of the moment, as I said, that are harmful to them. They have very intense relationships with others, which break up frequently. They don't let go of these relationships. They continue to stalk or follow the person that they're no longer involved with, whether it's a friendship or a romantic relationship. They don't let it go easily. They cut themselves. They make suicide attempts. They sometimes kill themselves too. We talked about them having a higher suicide rate. They are the cutters. We call them the cutters. They have eating disorders. So one of the things that a borderline will tell you is that they feel very empty inside. Remember that? We saw that once before. That feeling of emptiness and aloneness is characteristic of the borderline personality disorder, as well as bulimia. And about 50% of bulimics have borderline personality disorder. That feeling of emptiness and aloneness. They will do things to make somebody feel badly. If something happened to me, she'd be sorry, and then he puts himself in harm's way. So this comes in male and female form. Okay. We had an incident at one of the medical schools where a resident with a borderline personality disorder was interested in one of the medical students. And he, the resident, when she broke up with him because she realized something wasn't right about this man, he began to stalk her and follow her around the hospital and the medical school, and she'd see him coming out of stairways and elevators just when she was going to be in a certain place. She saw his car outside of her apartment complex. She called the police a few times because he was a stalker. He never did anything to her, but he didn't let go of a relatively trivial relationship. Right. Yeah, a typical ex. It could be a typical ex, but not really so typical, because there may be some borderline characteristics, but I doubt that you would marry somebody who has a borderline personality disorder. But these people are very charming, very friendly. They can be very, very attractive when you first meet them. This is a movie about a superwoman, a super ex-girlfriend, a superwoman who had a borderline personality disorder. One of the students told me about the movie, so I put the picture up. I haven't seen it, so I don't know. But it is that person who seems fine when you first meet them, but doesn't let go. Okay. The antisocial personality disorder is the psychopath, or the criminal. No superego, no conscience. They have no long-term attachments. They typically have conduct disorder in childhood. Most kids with conduct disorder, though, will be okay by the time they're 18. So if they're younger than 18, we call this lack of superego conduct disorder. If they are over 17, over 18, it is the antisocial personality disorder. And they make up a lot of the prison population. Okay. So that is the antisocial personality disorder. Here we have a criminal. Okay, now we mentioned this guy before. The avoidant personality disorder is somebody who is very shy and quiet and very afraid that people won't like him. So he's so fearful that people won't like him that he cannot make friends. So he would like to have friends, not like the schizoid who said, you know, let's get this over with, Doc, I don't care what you think. This guy really does care what you think. As a matter of fact, he cares too much what you think. And he is insulted very, very easily. You say something to him that you mean as a compliment, and he says, was something wrong? Why did you say that to me? Okay. Very sensitive to criticism and rejection. Okay. This is not social phobia. Remember, social phobia is a sudden onset of intense anxiety in a social situation. Okay. And it can come on de novo. It doesn't have to always be there. This guy has always been super sensitive to criticism. He would like to be close to people. He stays in the same job and the same relationship. Okay. So the social anxiety disorder is the inability to perform in a public situation. And by the way, social anxiety disorder is not only public speaking. It's also fear of using a public restroom and fear of eating in front of other people. Okay, so social anxiety disorder has a number of other variants. Okay, but this individual, it is the criticism. He's very sensitive. Okay. If you see a patient and you say, oh, hi, Mr. Smith, you're looking very well today, the patient will say, did I look terrible the last time you saw me? Is that why you're saying I look well? Okay. So they take every compliment as a critique, a criticism. Okay, so that's the avoidant personality disorder. Not social phobia. Okay, my friends, if you have multiple colored pens, do you have multiple colored pens? Some of you have that one pen that has all the colors in it that you click around. Does that mean you have a personality disorder? I know you do. That's why I showed this picture. I know this looks like when I'm teaching a class, I look around and I see who's got all the multiple colored pens and who's putting tabs in their book to mark their spaces. You all have some obsessive compulsive characteristics. All medical students do. You have to be organized in order to get through medical school. So some characteristics are normal. It is when your need to mark up every different fact with a different color becomes so intense that that becomes the focus of your attention, and you lose the focus of what I'm talking about. Okay, because keeping everything in order takes up too much of your attention. So these people are orderly, inflexible, perfectionistic. Okay. Friend of mine carries at least 12 pens, Faisal. Well, he may be a personality disorder, or he just may be a very organized guy. The question is, does this interfere with his functioning? Okay. And if it does, he may have the personality disorder. And they, by the way, these people will not laugh when they see these pens. They'll think that you shouldn't be making fun of their organizational skills. Okay, so they're not very funny. They're also very, very cheap. They do not spend money on anybody except if they must, even on themselves. They're extremely cheap with money. They rarely give people tips when they do something for them, and you know that in restaurants and certainly in other places, when somebody does something really special for us, we tend to give them a tip, somebody who's working. They don't give tips unless they absolutely have to. Okay. Okay, so we're talking about your friend. Okay, your friend with the 12 pens does well, which means that he's just the type and not the personality disorder. Now remember, we have to differentiate the personality disorder from the anxiety disorder. In OCD, the individual knows that he should not be marking with every individual pen, every different word, but he cannot stop himself. Because if he doesn't mark up the book with all these colors, he becomes so uncomfortable and anxious that he has to start marking again. Okay, so that is the anxiety disorder, OCD. This is the personality disorder. No insight. Okay. Okay. Okay, here's our poor dependent personality disorder. This guy is basically saying to this woman, don't leave me. I can't manage, I can't live without you. He has got very poor independent functioning. He is very, very clingy. He wants her to take care of him. He wants everybody to take care of him. He never says he disagrees with anything. He agrees with everything you say. He may end up as an abused partner. That is because he will not leave an abuser because he has to be taken care of. And he has to have somebody tell him what to do. As a doctor, this person will ask you what to do with his life. He'll say, should I get a divorce? Or should I change my job? What should I do, doctor? Okay, and of course you have to put it back on him. Well, Mr. Smith, this is really your decision. You don't make decisions for patients, but he will continue to ask you to tell him what to do. Okay. Again, that dependency affects the person's functioning. They do end up in very bad relationships. Okay. Now, when you meet somebody with a dependent personality disorder, they seem like everything you like, they seem to like the same thing. So you say, well, I really like this dish or this kind of food, and they say, that's my favorite. Or you say, I really like this movie, and they say, why, that's my favorite one. And of course, those things are only their favorites because they're your favorites. They don't have, as we said, independent functioning. Okay. So that is the dependent personality disorder. Okay, let's do some questions now, my friends. Okay, here we have a medical student who cannot stop studying until she has memorized all the notes for all her courses. She's always behind in her work and is in danger of failing her courses. She has not improved with counseling and feels that she really needs to know everything that's in the books. Okay, my friends, let's go. Answer the question. PD is personality disorder. How are we doing? Okay, it looks like we're out of time. And the answer is, this is a personality disorder. This is obsessive compulsive personality disorder. B is correct. Okay? Because this individual does have to do certain things. She is compelled to do them, but she has no insight into the fact that she shouldn't really do all of that. And this behavior is negatively affecting her functioning. So she's in danger of failing her courses because of her perfectionism and the fact that she has to learn every single fact in every single book. And in medical school, you know that you will never be able to memorize every single thing. You have to let something go. And one thing personality disorder patients like this cannot do is let anything go. Okay, she has to read everything and do everything. Okay, and that makes her inefficient. Okay, let's look at the next one. A 20-year-old patient tells the doctor that he's uncomfortable with girls and just does not know what to say to them. He also reports that he has a few male friends that he hangs out with and is doing well in his job in construction. This clinical picture is most consistent with, we have some personality disorders here. We have 3 of them. We have Asperger's disorder when it still existed. Okay. And then we have normal shyness. Normal shyness. What is this? Tell me what's going on with this young man. Okay, Haya is asking, why would she fail if she's studying everything? Because you can't possibly learn everything. And if you try to do everything, you may end up not doing anything. Okay. Okay, my friends, let's use the counter. Let's use your clickers for the question. Okay, click in your answers, please. Okay, some of you may have clicked in before, and I think we erased it by accident. So click in again, if you can. Okay. Okay. The answer is 55% of you got it right. This is a normal young man. This is normal shyness. Okay. How do we know this is a normal young man? Because he's doing well in his job and he has some friends. Okay. So this is a normal guy. Okay. He does not have any personality disorder. Okay. Remember that people with personality disorders have them in every aspect of their lives, at home, at school, all over the place. Okay. Should mention he is a male. Okay. 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 Let's look at this one. A 27-year-old says that she tried to commit suicide after a man with whom she had had 2 dates failed to call her again. What personality disorder is this? Start the counter. Okay. So this was a very trivial relationship that she had. She only went with this man twice. She only went out with him twice. And now he didn't call her, so she tries to commit suicide. Okay, my friends. 70% of you got this right. That is correct. It is the borderline personality disorder. Very impulsive. For trivial reasons, this individual has made a suicide attempt. Okay. Okay. Just one moment. If you give me just 10 seconds. Okay, my friends, just a moment. Okay. So this is the borderline personality disorder. And there's a couple of questions of what's the difference between OCD and OCPD. And we talked about that a couple of times, but I'll tell you again. I'm going to ask the class to tell Ibrahim what the difference is between OCD and OCPD, the big difference. The behaviors are very similar, you're right. But what's the big difference? Very nice. Everybody see that? That in OCD, in the anxiety disorder, the patient recognizes her behavior as a problem. And in the personality disorder, which is what this was, she doesn't recognize that she has a problem. Okay, so that's the big difference. How about this one? A 20-year-old woman enrolls in college. Okay? On the first day of class, she's called on, but the teacher tells her that her answer is incorrect. The next day, the woman drops out of school. What personality disorder is this? You can start the counter. Okay, so here we have some different personality disorders. What is this? Okay, yeah. 3 seconds, 2 seconds, 1 second. Okay, good. 75% of you got it right. That is really, really high. This question is very difficult for most students. You folks did really well on this one. It is the avoidant personality disorder. That is correct. That is, this individual is so sensitive to criticism and rejection, but mostly criticism, that she destroys her life by dropping out of school as soon as she's criticized, that is, she didn't do something right. As a medical student, you know how many times you have been criticized, told you are incorrect. You've got to roll with it. You've got to be able to recover from those incidents. You cannot say, that's it, I give up medicine. Okay, so these people do very badly. As I said, this is the avoidant personality disorder because they cannot tolerate any criticism. Okay. Okay, a 15-year-old boy is brought in by his mother for strange behavior. She reports that her son is often late for school because he spends more than an hour in the shower every morning. When asked about this, he says that he takes a long time because he's compelled to wash himself in a certain manner, and he has to repeat the whole process if he makes a mistake. He knows it sounds ridiculous and it makes him late for school and other activities, but he cannot seem to stop himself. Now, my friends, what is the diagnosis? Okay, let's start the counter. I'm smiling because I'm happy. I'm happy with your responses. Very, very nice. 76% of you got it right. This is OCD, the anxiety disorder. It is not a personality disorder because the young man knows that it's a problem. He says, I know it sounds ridiculous. He acknowledges that there is a problem, right, Haya? And so this is the anxiety disorder. Now, this young man will be helped by very high doses of antidepressants like SSRIs. This person not only will have no interest in taking any medication because there's nothing wrong with him, okay? So this individual is very willing to take medication because he knows he has a problem, okay? So you might see all of this behavior in the personality disorder, okay? Except you won't see this part, that he has to repeat the whole process if he makes a mistake. But he thinks everyone should wash himself in the same way so that they don't miss anything. And he doesn't think it's funny when you think it's strange. That would be the personality disorder, okay? But this guy knows that this is a problem, and it is interfering with his functioning. Okay, good. Okay, next group of disorders used to be called organic disorders. Okay. These are the cognitive disorders. These are also called neuropsychiatric disorders. That is, these are disorders that have behavioral abnormalities associated with them. But the behavioral abnormalities are caused by problems in the brain itself. Okay. So Tourette's syndrome may, this is the individual, and it starts in childhood, who makes abnormal facial movements, may blink excessively, may make sounds. So Tourette's syndrome, you must have both the motor, the blinking, for example, and the sound making, both of them, motor and vocalizations, to have Tourette's syndrome. It typically starts in childhood with the motor tics. And the tics have to last for more than a year for the diagnosis of Tourette's syndrome. So a tic just means it's a useless movement or vocalization. This gentleman is an American basketball player who is a very successful person. Again, I like to show people who are successful despite the fact that he has a very severe case of Tourette's syndrome. And he has quite a number of tics and vocalizations that he engages in. Now, while he's playing basketball and is very involved in that, the tics do not appear. But when he stops playing or just before he's playing, he shows a lot of them. And one of the things he does is he touches everybody on the team before he can start playing. Okay. This is more common in males, Tourette's syndrome. It's associated with abnormal dopamine regulation. And teachers who have children like this in their class, or parents, will tell you, this kid can't control himself. He keeps shouting things out. Sometimes they shout out really bad words too. Okay, but the child or the adult cannot control their tics. So it may be reported as a problem child, a learning problem, ADHD. And the treatment is a high-potency antipsychotic like haloperidol or Pimozide. So haloperidol and Pimozide are both indicated for the treatment of Tourette's syndrome. Okay. Risperidone is an atypical antipsychotic which may be used for Tourette's syndrome. Okay, but it is not yet approved for the management of Tourette's. And the boards will always focus on what drugs are approved by the Food and Drug Administration. And these are the two that are approved for Tourette's. Let's take a look at this question. The parents and teacher of a 7-year-old boy note that he frequently shrugs his shoulders, often he blinks his eyes excessively, and at other times he shouts out words for no reason. In adulthood, this child is at risk to develop which of the following conditions? Okay. Okay, let's put the timer on, my friends. how are we doing? Let me take a look at the counter. So this is a double jump question. First, you have to know what's wrong with him, with this kid, and then what is that associated with? And, well, you could take more chances. There are not that many of you answering this question. Think back, think back, think back. Okay, we did talk about this already. And the answer is OCD. Remember that OCD and Tourette's syndrome are comorbid. Both of them involve the caudate nucleus as well. And they both involve abnormal neurotransmitter regulation. In Tourette's, it's believed to be more closely associated with dopamine. In OCD, with serotonin. Okay, good. Now, delirium and dementia are very important topics in medicine. And you will see patients with these syndromes. Commonly, these syndromes are more common in elderly patients. You have to be careful not to mistake delirium for dementia, okay? Because typically dementia is not treatable, and delirium is. So delirium is a syndrome that we see in medically ill patients or patients who are withdrawing from substances or under the influence of substances. And the hallmark of delirium is a clouding of consciousness. The person is not completely awake, okay? Like some of you earlier on today. No, I'm just kidding. Okay. Delirium, you're not completely alert and awake because of some neurological process, okay? It has an acute onset. It has a fluctuating course. It tends to be better at certain times of the day and worse in the evening, typically. The individual's memory may be impaired. They often have visual hallucinations. That's a hallmark of delirium. That is, seeing things that don't exist. It usually means there's something wrong with the brain itself. A disrupted sleep-wake cycle, and what we have to do with patients who have delirium is find out what's causing it. Find out the cause and remove it. Treat the patient for the illness that they have that's causing the delirium, and the symptoms will typically resolve. They'll go away. The patient will be okay. In contrast, in dementia, there is a normal level of consciousness. If you're talking to a patient with Alzheimer's disease, that person is awake and alert, but they cannot answer your questions. They cannot even tell you who the woman sitting next to them is, even if it's their wife, okay? Because they don't remember anymore who anybody is. They don't remember where they are. They don't remember simple things like the name of this object. If I showed the patient this object and I said, "What is this?" the patient would say, "You write with it?" I'd say, "Yes. But what is it called?" Okay, the inability to get words is one of the earlier signs of dementia. Okay, what do we call this? Okay, those things are very impaired in the presence of a normal level of consciousness. So most of these are not reversible. So one rule is you cannot diagnose dementia until you rule out delirium. Okay, my friends. Let's take a look at this question. The mother of a 35-year-old man with AIDS, but no history. He has no history of psychiatric illness. Reports that yesterday she observed him sitting up in bed, punching the air, and grabbing at insects, although none were present. The patient's CD4 count is less than 100 cells per millimeter cube, and he has a high fever, so that's 103 Fahrenheit. The mother is concerned about these symptoms because the patient's older brother has schizophrenia. This clinical picture is most consistent with, and we can start the counter, and we have HIV dementia, cryptococcal meningitis, schizophrenia, brief psychotic disorder, or amnestic disorder. Okay, let's see how we're doing here. Remember the rule that I told you about just a moment ago. Don't forget the rule. I think I reminded some of you of the rule. Okay. The rule is do not diagnose dementia until you have ruled out delirium. This patient has cryptococcal meningitis. Okay. How do we know that this is not HIV dementia? Because we see symptoms that are more consistent with delirium than with dementia. We also see a high fever. Okay. In dementia, we do not see a high fever. We also see psychotic symptoms, visual hallucinations, which we rarely see in dementia until the very late stages. Plus, so we must rule out the possibility that this is caused by a brain infection, an opportunistic brain infection. And cryptococcal meningitis is one of the infections we do see in patients who are immunocompromised. Okay? So you must rule out delirium caused by a treatable thing before you can say HIV dementia. HIV dementia is seen in the late stages of AIDS, where the brain has basically been attacked by the virus and the individual has many different symptoms, but does not have an acute illness. Okay, my friends? Okay, good. Okay, our next topic is Alzheimer's disease. And what we're going to do now is we're going to take a break. Okay, my friends? Let us take a break, and I'll see you in 10 minutes. Last hour today, but I will see you again tomorrow. We'll be doing lots of questions tomorrow, and we'll be doing some very high-yield topics like ethical and legal issues in medicine. Okay, right now, though, we are talking about Alzheimer's disease. We're talking about dementia in general, and Alzheimer's disease is the prototype of dementia. Okay, so it is a progressive disorder. Most dementias are progressive. That is, they take many, many years to fully develop into their most severe form and to ultimately kill the patient. And most of them do within 10 years or 15 years sometimes. Okay. So it can be even longer occasionally, but they are slow moving disorders where the brain is basically degenerating. Alzheimer's disease represents about 2/3 of all dementias. And as people get older, dementia becomes more common, and Alzheimer's becomes more common. And in people over the age of 85, 20% have dementia, typically Alzheimer's. Alzheimer's is more common in women, and there is a genetic component to it. Okay, and I show this picture of a former United States president. This is Ronald Reagan, who, after he left office, developed Alzheimer's disease and lived for about 10 or 15 years after developing the disease. Okay. Alzheimer's has been linked to a couple of chromosomes. It's been linked to chromosomes 1 and 14, which are associated with early onset Alzheimer's, that is before age 65. Chromosome 19 is associated with the APOE4 gene, which is confers a risk for Alzheimer's. One copy, 47% risk at age 65, and if you get one copy from each parent, there is a 91%. That is, you're almost definitely going to get Alzheimer's by the time you're 68. And chromosome 21, of course, because patients with Down syndrome do develop Alzheimer's disease. Let's take a look at this question. The autopsy of the brain of a patient with Down syndrome is most likely to reveal, and we can start to counter, abnormalities of the basal ganglia, damage to the reticular system, amyloid plaques, frontal lobe hypertrophy, or increased size of the locus coeruleus. Okay, my friends, what do we see in the brain of a Down syndrome patient? Okay. I like what I'm seeing. More of you can chime in on this one. Okay, yes, this is amyloid plaques because patients with Down syndrome do have amyloid plaques. That is a hallmark of Alzheimer's disease. Now, amyloid plaques and neurofibrillary tangles, though, are seen in other diseases of the brain. So they are not exclusive to Alzheimer's. Okay. We also see amyloid plaques and neurofibrillary tangles in normally aging brains. Okay. So it does not immediately indicate that there is pathology, neuropathology. Okay. Okay, so the pathology of the brain and Alzheimer's, and many of you have seen this before in other parts of the course, in gross anatomy, etc., and neuro. That is, the brain is basically shrinking, the ventricles are getting larger, but this is not diagnostic for Alzheimer's. There are many disorders where you see this. There's believed to be reduced levels of the enzyme needed in the manufacture of acetylcholine. That's choline acetyltransferase. Okay. Microscopic pathology, we talked about the plaques and the tangles and degeneration of the neurons. Now, the management of Alzheimer's, it's an unfortunate fact that we really have very little we have very little in our armamentarium for Alzheimer's disease. We try to support the patient and the caregiver. We treat the associated symptoms, and many times patients with Alzheimer's will develop depression and anxiety as they realize that they're losing their mental functioning. We advise caregivers to not move the furniture around, to keep everything about the same. The medications that we have are primarily acetylcholinesterase inhibitors, and the goal of these drugs, of course, is to stop the breakdown of acetylcholine in brain synapses so that acetylcholine will persist. And acetylcholine, of course, as you know, is the learning neurotransmitter. It's important in memory and learning. Even if we give patients anticholinergic medications, that is, we give it to them for GI problems or for other issues, anticholinergic medications not only cause dry mouth and all the other associated peripheral symptoms, but they also cause confusion because they do affect acetylcholine in the brain as well. Okay. Now, a newer agent to treat Alzheimer's disease is memantine, which it works by a different mechanism. It is an NMDA receptor antagonist. Okay, and the action of memantine is this. Okay. It is believed that glutamate elevation is one of the reasons that neurons are destroyed in Alzheimer's disease. So it's believed that sustained elevation of glutamate activates NMDA receptors. This results in calcium entering the neuron and essentially killing it. Okay, so glutamate and calcium are both toxic to neurons, and the chronic overexposure to calcium leads to ultimately nerve cell degeneration via excitotoxicity. Okay, and the nerve cells die. Now, the action of memantine is to block the NMDA receptors and prevent this whole sequence from happening. Okay, my friends. Now, I have the question that was on the boards from which I based that whole discussion. Okay, my friends. A 75-year-old woman with Alzheimer's is being treated with memantine. What is believed to be the basis of the therapeutic action of memantine on neurons in the brain? Okay, we can start the counter. To inhibit the action of acetylcholinesterase, inhibit acetylcholine itself. Increase the influx of glutamate. Facilitate the influx of calcium. Block the influx of calcium. What is the right answer? Okay, let's see how we're doing. We can use some more checkers? Okay. Okay, my friends, the answer for this one is E. Okay, and 31% of you got this right. To block the influx of calcium, remember that calcium and glutamate are toxic to neurons. Okay, so we block the influx of calcium. Okay, and I'll show you again the action of memantine. It is the overexposure to calcium that leads to the cell death. So we block the influx of calcium by ultimately when we block NMDA receptors. Okay, good. We don't know that, Abraham, we don't know that patients with Alzheimer's disease have excess glutamate. Unfortunately, we don't know a whole lot about, we have theories. There are always theories about these things, but this is an accepted theory, and this question was on the boards. Okay. Okay, a 75-year-old man with Alzheimer's keeps wandering out the front door of the apartment he shares with his wife. His wife wants to keep him at home if possible. The doctor should first recommend that the wife, we can start the timer, get him admitted to a nursing home, give him antipsychotics, give him donepezil, accept this as the new normal, orient him regularly, and label the doors as to their function. How are we doing on this one? Oh, a lot more of you are answering on this one. Okay. Very nice. Almost everybody got it right. We have an 88% correct rate, and the answer is E. That is, remind the patient of what's going on. And that's what we do with patients who have dementia, is we continually tell them who we are, where they are, what's going on, because they forget very quickly after we tell them what's going on. So remember that donepezil will only slow down the progression. It will not reverse the losses. These drugs, the acetylcholinesterase inhibitors and memantine, only slow progression. They do not cure, and the person has lost function, it will not come back. Okay? And they only delay the inevitable. Okay. Many patients nowadays, Dahlia, are taking acetylcholinesterase inhibitors early after diagnosis, and memantine is very often added to the acetylcholinesterase inhibitors. They're very often given together. Okay. Okay, the second most common type of dementia is vascular dementia, which is associated with small strokes that occur as a result of hypertension or valve disease. So the patient will typically have another diagnosis. They'll have a diagnosis of cerebrovascular disease, hypertension, and the patient then begins to have episodes of memory loss. Now, the episodes may clear. The patient may get their memory back if the clot does not destroy brain tissue, but if it does, there will be a permanent loss of functioning. And it's not only in psychiatric functioning, but with vascular dementia, the clots go everywhere in the brain, including to the motor areas. So in Alzheimer's, you do not have motor symptoms until the very end of the disease. But in vascular dementia, you have motor symptoms along with the cognitive or the intellectual symptoms. Okay, so there very often are neurological signs in vascular dementia. So they will tell you in vascular dementia that the patient has hypertension or valve disease and is more typically male, because men are more likely to have these disorders at a younger age, and that the symptoms tend to come and go at first and then come and stay. So the patient will have what we call a stepwise downward progression. They'll have a small stroke, they'll lose some of their intellectual functioning, they'll stay the same till the next little stroke, then another loss, then they stay the same, and then another loss. And what we have to do is aim at stopping the strokes. So we use thromboembolic agents. There are some surgical procedures that can be used to clear the carotid arteries. We use aspirin also to keep the blood thinner, and a variety of other medications. Okay. Pick's disease is another dementia. It is a very rare one, and this is frontotemporal dementia. That is, the frontal lobes and temporal lobes are affected first. So the first thing you see are personality changes. The individual seems very different than the way they used to be. The management is, we cannot use the same medications we use for Alzheimer's, but there really is no treatment for Pick's disease. So we see the personality changes early and disinhibition early. Dementias can also be caused by prions. Dementia caused by a prion. Here are just some of the dementias that are caused by prions. And prion dementia is very, very fast. In contrast to the other dementias, which take 10, 15 years to kill you, prion diseases, people generally will die within a year. Okay. It tends to start at a younger age, and it's very difficult to diagnose because there are many symptoms like anxiety and also physical symptoms with no medical explanation, but there is no treatment in any case. Okay. Huntington's is a relatively rare neurological disorder that can present with psychiatric symptoms, which is why we're talking about it here. Okay. This is a photograph of a famous American who wrote folk songs and performed them, and was the he inspired many future entertainers in the United States with his work. And his name was Woody Guthrie, and he died of Huntington's disease. So he's the most famous Huntington's patient in the United States. Now, Woody Guthrie, his first diagnosis when he was 38 years old was paranoid schizophrenia, because he was paranoid. He was psychotic. He was taken to a hospital. His history revealed that his mother had died in a mental hospital, diagnosed with paranoid schizophrenia. So he was given the same diagnosis. And in fact, neither one of them had schizophrenia. Both of them had Huntington's disease. So these abnormalities, depression, psychotic symptoms, are seen in Huntington's disease. Abnormal writhing movements, and the history will be that the mother died after a prolonged illness. The patient may or may not know that the mother, or whoever the parent was, had Huntington's. And of course, 50% of children of parents with Huntington's will also develop it. It's up to the child to decide whether or not he wants to be tested for the gene for Huntington's disease. Some people want to know that they're going to develop the disease later on in life. Some people do not want to know. So it's up to the individual to decide whether or not they want to know. Okay, so death sometimes in 15 to 20 years. So it's a long and slow process. And the end of, in the old days, patients had to go into psychiatric hospitals because of their psychiatric symptoms. Now they can be maintained in a nursing home, non-psychiatric setting with medication for their psychiatric symptoms, antipsychotics and antidepressants. Okay, Parkinson's disease typically starts in the 50s, okay, or the 60s. It is associated with low levels of dopamine in important brain areas, substantia nigra in particular. And the symptoms are, there are lots and lots of motor symptoms associated with Parkinson's, that is slowed movement and the resting tremor, the pill rolling tremor, the absence of facial expression, the rigidity, we call this cogwheel rigidity because when you pull the patient's arm out, it works like a cogwheel, and the inability to initiate movement, and therefore the patients don't pick their feet up off the floor as they're walking, and they have a kind of what we call shuffling gait. So this is a characteristic of Parkinson's disease, this whole group of symptoms. Now, these symptoms are associated with low dopamine. And sometimes when we give patients antipsychotic medications and we're trying to block their dopamine receptors, and we're talking about that in a little while, they end up looking like Parkinson's patients because we lowered their dopamine so much that they have all of these symptoms, like a Parkinsonian patient. But it's related to the use of antipsychotics. Some are worse than others at causing these Parkinsonian symptoms. Okay. And Lewy body dementia, and we talked about this earlier, is a consequence of or is comorbid with Parkinson's disease. You may remember the sleep disorder that's also seen in patients who ultimately develop Parkinson's disease. Does anybody remember what it's called? What's that sleep disorder that's associated with Lewy body and Parkinson's disease? REM sleep behavior disorder. Okay, remember REM sleep behavior disorder, where the person's body is active in REM. Okay. Okay, let's take a look at this question. A 35-year-old man begins to show memory loss and personality changes and dies within 1 year. Neurofibrillary tangles are found on brain autopsy. What is the most likely diagnosis? Okay. What do you think? Let's see how you've done on this question. Oh, not too many of you are clicking in. Come on, some more of you. Let's see, we have 46 students in the class. So far we don't have terribly many answers. Let's see if you can take a chance on this. There are a couple of keys here. The biggest one is dies within 1 year. He begins to show symptoms and then he's dead really fast. What is this? Okay, very nice. Okay, yes, when I gave you that little hint, although it was there all the time, it's CJD, Creutzfeldt-Jakob disease, a prion disease. Okay, and remember that you see neurofibrillary tangles in a number of neurodegenerative diseases. So that is CJD. Memory loss and personality changes. Okay. Okay, what is meant by a prion? Okay. Well, we don't have too much about the prions here, but it is not a virus and it's not a bacterium, but it can cause disease and it can replicate very, very quickly. Right. It is related to abnormal protein formulation. And they are very strange diseases. Some of the other ones are associated with eating animals that have the disease, eating particularly the brains of animals that have these diseases. Okay, so the prion diseases are very rare, but they kill very quickly. Okay, my friends. Okay, here are just some drawings that show that a patient's neurological functioning is impaired. That is, the doctor draws a picture like this and says to the patient, please copy this drawing. Now, in the first case, the patient is copying the drawing all right, but the patient can't seem to stop copying. They keep on going. They're unable to inhibit themselves. And that is something called perseveration. And it involves the frontal lobes. That is, the frontal lobes do inhibit the rest of the brain, and if they are damaged, we have this disinhibition of behavior. We talked about that when we talked about frontal lobe dementia. Okay. These two are caused by similar brain damage. That is, the doctor draws this picture, the patient tries to copy it and draws this one. The doctor draws a clock face, and the patient neglects the left side. And both of these are due to lesions in the non-dominant parietal lobe. Okay. We're not going to talk much about different neurological dysfunctions. I'm going to leave that to neuro. But we are going to talk about the frontal cortex because that's the part of the brain that's most closely involved in behavior. Okay. Okay, so the frontal cortex is associated with speech, personality, abstract thinking, some of these things that make people. And our frontal cortex is much more developed than in any other species. Capacity to start and stop, so the frontal cortex is inhibitory, and also the ability to concentrate. Lesions of the dorsolateral prefrontal cortex typically lead to problems with decision making because that is the part of the brain that's the so-called executive part of the brain. So when it is damaged, patients will be apathetic. That means they have no interest in doing anything, low drive, problems with initiative, poor grooming, decreased attention, poor abstract thinking, and if it's the dominant hemisphere, with the inability to speak words. So that would be also seen in a patient who may see this, who does not have Alzheimer's disease, and you say, please name this object, and the patient cannot get the word. He knows what it is, but he cannot get the word. Okay, so that is typical of Broca's aphasia. So the patient with damage to the dorsolateral prefrontal cortex is docile, dirty, and dim. So that's a little mnemonic for you to remember with damage to the dorsolateral. Lesions of the orbitomedial prefrontal cortex lead to changes in behavior, such as disinhibition, withdrawal, fearfulness, lack of mood control, violent outbursts, explode into orbit with damage to the orbitomedial prefrontal cortex. And this is a picture of a very famous case, the skull of a person who was a very famous case in medicine, because this patient was one of the first people to demonstrate the function of the frontal cortex. Okay. Okay, was he in a circus? Faisal is asking. No, this was a gentleman, some of you may have read the story, because this was a naturally occurring event, because in those days we didn't have all the testing. It was 1861, the ability to test the brain, etc. So this man was right. He was a railroad worker. That's correct. He's a railroad worker. His name was Phineas Gage. Okay. He was working on the railroad, and he was tamping dynamite down with a metal rod. Okay. The dynamite exploded, and the metal rod went through his head. Okay, the metal rod was pushed up fast and hot through his head and damaged severely his orbitomedial prefrontal cortex. How do we know that? Because we still have his skull. Okay, and his skull was used to show forensically what happened and what part of his brain was damaged. Okay, now the rod was very hot, and it also was very fast, and it flew out behind his head. Okay, he did not walk around like this. Okay, so he was not in the circus. Okay, the heat of the rod probably cauterized the vessels, which is probably the reason that he lived, because in those days you didn't live with an injury like that, but he did live, and but his behavior was very different. And his friends and his co-workers said, it's just not Gage anymore. it's like a different person here. His intellectual functioning was okay. His ability to work, his motor functioning was okay. But he was explosive, difficult, uninhibited, and he had been a very mild-mannered, pleasant person before that. And now he was completely different. Okay. And that was evidence for the function of the frontal cortex. Okay. Okay. Now, in the bad old days, prior to the development of medications for psychiatric patients, there was a procedure that was touted as being a panacea for mental patients, that this would relieve their hallucinations and delusions and make them calm and happy. And it was done to many thousands of psychiatric patients in the United States. And it was called a prefrontal lobotomy. And a scalpel was inserted in the top of the eye socket up, okay, and then moved from side to side. So the bone, the very thin bone in the top of the eye socket was broken through with the scalpel. The blade was moved across and the frontal cortex was separated from the rest of the brain. Okay. It did calm down agitated patients, but it also changed those people forever. And they were completely different with respect to their personalities. So, but there was really nothing much could be done prior to 1950 to help patients when they were very agitated and very psychotic. About the only thing we could do was give them a sedative, which is what was done in, and keep them in an inpatient unit for their whole lives. They were kept in inpatient psychiatric hospitals until the development, and we talked about that, of chlorpromazine and the other antipsychotics and the antidepressants. Okay. So this was used for a few years, but not for very long. Okay. Okay, let's see how we're doing on time. Good. Okay, so the neurotransmitters we'll talk briefly about because it is alterations in neurotransmitters that are responsible for the effects of psychoactive drugs. Acetylcholine is a neurotransmitter that has many roles in the body and also has a significant role in learning and memory. Okay. And that's why anticholinergic effects, as I mentioned earlier, can cause confusion. And we know that acetylcholine is involved in the symptoms of Alzheimer's. Okay. Norepinephrine, dopamine, and serotonin, important behavioral neurotransmitters. Norepinephrine also has many other functions in the body. Sympathetic nervous system, emergency response. It's also associated with mood. We know that low levels, you'll recall, of norepinephrine are associated with depression. Okay. And one way that this was discovered was that patients taking drugs that decrease norepinephrine in brain synapses, like antihypertensives medications, caused depression. And they still can. You may put your patient on an antihypertensive, and a few weeks later the patient comes back and says, I feel like life isn't worth living anymore, doctor. When did this start, Mr. Smith? Well, a few weeks ago. And you realized that it started when you gave them that beta blocker. Okay. So the antihypertensives that cause the least amount of depression are the ACE inhibitors. ACE inhibitors are less likely, although they can also deplete norepinephrine and cause depression. Okay. So the locus coeruleus, of course, is the site in the brain where the norepinephrine is produced in the upper pons. The major metabolite of norepinephrine is vanillomandelic acid, VMA. And we talked about the monoamine hypothesis of the mood disorders. That is, low levels of monoamines are associated with depression and high levels are associated with mood elevation. Okay. Dopamine is a very important neurotransmitter. It's the feel-good neurotransmitter. We've talked about that. The D2 receptors are most important with respect to psychotic symptoms. That is, D2 receptors are closely associated with psychotic symptoms because we know that all antipsychotic medications at least block dopamine 2 receptors. The major metabolite of dopamine is homovanillic acid, okay, which is measured in some psychiatric research because dopamine itself, and like the other neurotransmitters, cannot really be measured well in body fluids. So we measure the metabolites to give us an idea about what neurotransmitter function is like. Okay. And serotonin is manufactured, of course, in the raphe nuclei. It is very important in mood and anxiety. And depressed serotonin is associated with mood, with depression, with anxiety, and with poor impulse control. Okay, and they've asked about that on the boards. They've had questions where the patient has low 5-HIAA, which is the major metabolite of serotonin, low levels of 5-hydroxyindolacetic acid, and has been getting into legal trouble because he cannot control his temper. Okay, there is a disorder called, that is an impulse control disorder, where a patient becomes very, very agitated and gets into trouble. It's called intermittent explosive disorder. It's closely associated with low serotonin, and it is treated with SSRIs. Okay. Good. Now we're going to start on psychopharmacology. This is one of my favorite subjects. I hope it's one of yours as well. And remember that prior to 1950, there was no psychopharmacology. All we had was sedatives. We would give a patient sedatives and put them in a hospital. And patients with schizophrenia would spend their lives there. Patients with bipolar disorder often did spend their lives there, at least a large part of their lives, in those institutional settings as well. Okay. But now we have medications we can use. Okay, so the first group of medications we'll be talking about are the antipsychotics. And the antipsychotics are used to treat psychotic symptoms no matter what the cause. And the antipsychotics are also antiemetics. And in fact, the antipsychotic qualities of the antiemetics were discovered when patients were given drugs to stop nausea and vomiting. And also, if they happened to have psychotic symptoms, the psychotic symptoms would go away. That's where the dopamine hypothesis came from. That it must be, since we know that anti-nausea medications lower dopamine or block dopamine receptors, it must be dopamine receptors that are involved in psychotic symptoms. Okay. So it's used, these drugs in other forms, like compazine is used as a nausea and vomiting seasickness drug, and compazine is very similar to chlorpromazine in its structure. Okay. So all antipsychotics block dopamine 2 receptors. The problem with the antipsychotics, one of the problems is that they're not clean for the dopamine receptors and block other receptors. So they block alpha adrenergic receptors, leading to orthostatic hypotension. They block cholinergic receptors, leading to anticholinergic effects. And they block histamine receptors, leading to antihistaminergic effects like weight gain and sedation. Two things that we really do not want to see when we're giving patients an antipsychotic. Antipsychotics and antidepressants also block histamine receptors, many of them, and cause weight gain. So people with a mental illness have to deal with that problem as well. Do you think a person with schizophrenia is concerned about their body weight, my friends? We're going to end pretty soon. Do they care about their body weight? You say no, my friends. People with schizophrenia are people just like you and me. And yes, they are concerned with what they look like and their body weight. And that's one of the reasons for non-compliance with antipsychotics, is because of their tendency to cause body weight. Okay, so remember that people with schizophrenia want everything that everybody else wants in the world. They want to have children, they want to have families, they want to have a job, they want to have a means of having a good life. Okay. Okay. And Rothani has asked me a question: is it true all patients who take antipsychotics have Parkinsonian symptoms? No, not all patients do, but many patients do, because antipsychotics block dopamine receptors and the patient ends up sometimes with Parkinsonian symptoms. However, the Parkinsonian symptoms can be treated effectively in patients who are taking antipsychotics using anticholinergic agents. Remember that acetylcholine and dopamine are kind of this relationship. So if we push down acetylcholine, dopamine comes up a little bit, and the patient's symptoms, Parkinsonian symptoms, will be relieved. So that's the way we relieve those Parkinsonian symptoms. But we'll talk a little bit more about that tomorrow. And I just want to leave you with the thought that people with mental illnesses have all the same needs and wants that everybody else does, and our job is to try to make their lives as normal as possible, with the understanding that all psychoactive agents only control symptoms. None of them cure. Okay? So when the patient stops taking their antipsychotic, their symptoms, unfortunately, will return. And the same is usually true of the mood stabilizers and the antidepressants as well. Okay, my friends, we're finished for today, and we'll be starting with the antipsychotics, a little bit more about them tomorrow. Please have a nice evening. Tomorrow's our last day together. I'll see you then.